94 we did the first heart transplant in India. But then the last 2 years, the story has suddenly changed. Some facts. From 2016, more than 350 transplants were done across India. I'm very proud that in my ecology of Fortis Hospital, between our 5 hospitals, Balu, my ex-roommate from KEM, leads the pack, and we all are actually led by him. 2/3 are done of Indian transplant by these 5 Fortis hospitals. The entire Europe in that period did less than 100 transplants. We suspect that last year India did world's highest transplants. So we are come there. 82 centers across India performing heart transplants, including government teaching hospitals in smaller cities like at the Nizams, AIMS, PGI, Jaydeva. Places like Kottayam Medical College, Belgaum Medical College, Aurangabad have started doing transplants. Improving donor situation across, and last 3 years in Karnataka, Tamil Nadu, Telangana, Kerala, Andhra, we have seen the donor situation is almost jumped 4 times more. As I told you, 3,100 patients are waiting in United States at any time registered, and in our country that situation is very grim. The National Organ Transplant Act was passed by Parliament in 1994, and regularly once the act was passed, immediately the southern centers and the western states came up with the state coordination committees. The NOTO, the National Organ Transplant Act, was amended in 2014, and then most of the states quickly took it up. After that, everything is changed. And also now that the Indian central government has formed Apex Organ Sharing and Coordinating Organization called NOTO. With NOTO, we are now really flooded with organs. And with the Indian kind of jugaad that we have, that the frugal innovations that transporting organs from anywhere that we wish, we are in a very different situation now. We have been picking organs from small places like Amravati, Akluz, taking them to Chennai, taking them to Madras. We have formed between the 5 departments of Fortis, between Chennai, Bangalore, Mumbai, Mulund, Kolkata, and Delhi, a single team. And so we have a lot of manpower, a lot of jugaad together. It's very routine for us to be doing a heart transplant of a donor recipient between Bangalore and Kolkata, Bangalore and Delhi, and everything works out well. We are still within time. Nowhere in the world, by passenger flights, organs are taken. Nowhere in the world. Nowhere in the world this green corridor business happens. There is now a very thick partnership between government, police, and the surgeons. We have divided Indian airports into Class A, Class 1, Class 3, and accordingly our action plans are different. Organ donation sentiments are rising due to combined efforts of media, hospitals, NGOs, but the religious organizations and religious preachers are the most important people, and they can make a lot of change. Better government organizations, streamlining between state and central cooperations. This child who is standing with me there was my last pediatric heart transplant. For this boy, I got the heart from Vizag. Visakhapatnam is pretty far, and that's a Class 2 airport. And we picked up that organ. We had an Air Asia flight early morning. So my Karnataka government guys and the Andhra Pradesh government guys got up in the middle of the night, spoke to each other, mailed each other so that there was a documentary clearance. That really made us felt very touched because we never knew that government guys will help like that. The police on both sides, Vizag and Bangalore, helped us. The cross clamp putting on the donor heart, and Bangalore, my hospital is in Banagata Road, which is the opposite side of the airport. The heart getting transported to my hospital, we finishing the transplant fast, and cross clamp off in my OT. The time taken was 4 hours 10 minutes. This is the height of jugaad. But we have perfected across the country, whether it is in Ahmedabad, whether it is in Kolkata. The things are now pretty well set between government and the private bodies. Most of our hospitals are helping us quite a lot. Fortis, we have fantastic cooperation. They are not wishing any profit from that. Whatever brand value they get from it, they are happy with that. Waitlist in India. Problem in the Western world, Japan, Southeast Asia is of too many patients waiting for heart. Problem in India is patients are there and we're not having it on the list. The cardiologist surgeon team, we don't have to think theoretically of a heart team, just the cardiologist and the surgeon. And the third part of the team is the physicians, the real fathers of the patient, who refer these cases. It has to be between us. And we have to start pressing the button early. Everything has to be on the smartphone. And the fourth guy comes in the picture when the button is pressed is the medico-social worker. And then the heart transplant team is later on, that you need not bother. The present availability of multiple transplant teams and their capability to innovatively pick up donor hearts from even distant places, what we need now most is the hands-on cardiologist involvement. 186,000 people die on Indian roads annually, mostly by head injury. And all these head injury patients are possible organ donors. Donors. 10% of this, if we can convert, I think we will be operating transplant list of the whole world. With a good medical and government teamwork, South and Western states may leave India and the rest of the world behind in this area. The final therapies are heart transplant and VADs. So surgeons must be involved faster. Morbidities can be very expensive. That is why surgeons must be involved in the planning faster, and they know the most. Heart transplant today is 25 lakh. Temporary VADs are 10 lakhs. VAD to bridge are 55 lakh. These are the final costs when they're going home and not what is advertised. Mostly it's an out-of-pocket expenditure. Hence, somewhere in the middle of the natural history curve, beginning at the NYHA class 3, the trigger should be pressed by the physicians. Devices like ICD, CRT, CRTD in patients who are having the transplant possibility in the horizon, it should not be done. Dedicated non-interventional heart failure cardiologists in India is still a rare breed, it's a dream, and hence interventional cardiologists, EP specialists, and the CT surgeons have to be tied together, along with the physicians. We have learned in the past that IABPs and ECMOs, faster you put, earlier you put, trigger should be lower, then you get very nice outcomes. It's the same with transplant. Early referral I stood. Results, what's happening in India? This is international. If you look over 23 years, look at that, the red line. The red line is 2002 to 2008. And the violet line on the top is 2009 to 2015. The results are quite superior. What's happening in these 5 centers of Fortis, and wherever we have gone and helped, and those numbers we include in our numbers. Total numbers that this whole ecology has done is 356. Look at the red line. Red line is transplant, 256 transplant, done between 2012 to 2017. That's a very good survival. But if you look at the VADs done at the same time, after 1 year, the VAD survival start dipping, because our patients come from official areas. They can't manage their VADs. Whenever we get a patient from abroad, we get their doctors also, we train them and we send them back, and then we remain on WhatsApp and video calling, etc. These are all technical slides I'm going to skip through. Matching donors is mostly by ABO. The current guidelines, it is the gold standard. There are 2 ways of doing. We do it by cable approach. The consequences for you to know is biatrial connection means less atrial contribution to the stroke volume. Resting heart rate is faster, and the acceleration to the heart rate is slower during exercise because of denervation. Diurnal changes in blood pressures are abolished. Diastolic dysfunction is very common because the myocardium is stiff and some degree of rejection and possibly from denervation. Doing the biopsies is very expensive, so we depend more and more on echo. My anesthetists are becoming very sharp, extremely sensitive on echocardiography. Day in and day out, they see heart live. So today, I have come to rely on echocardiography more on my anesthetists than anybody else. That's the story across South. These are again technical slides I'm going to skip. Biopsies, as I told you, they are expensive. We are not doing as many. The heart mate, if we cannot do transplant or if you have a foreign patients, today the VADs have now become very sleek. If you look at the LVAD3, the American government about a month and a half ago passed, the FDA approved it for destination. And now we have this HeartMate 3, 83% survival. HeartMate, the heart transplant is 82% survival. 83% survival, 10% stroke, 1% thrombosis, HeartMate 3. The organ donations per million. Across India, it is still below 1%, 0.4, 0.5%. In the world, it has gone up to 36%, 36 per million. The organ donation rate is rising in India, but it is not to the mark. And after Bombay or after Gujarat up, it's quite a sad affair. Which are the countries people are willing most to donate? Colombia number 1, India number 2. But the Indians don't know, even they are willing, what should they do? The Mohan Heart Foundation and us, we have created an organization called Fort Fortis Organ Retrieval and Transplant, and of course the Mohan Heart Foundation. The number below is Mohan Heart Foundation, and if we go Fort or Fortis, you will go to our Fort program. There will be an application form. All the people need to do is just fill up the application form and send. Once you send, then our team will do the rest. See that you are registered with the center, registered with your state. The smart card will come to you. You can keep it in the wallet, tell everybody else in your society. And when time comes, everything is registered. So this is a sequence, and that's the bird eye view of what's happening in our country. Thank you very much.
Thanks,
and if
sir.
there are any questions, I'll be delighted.
I would request chairpersons to give memento to Dr. Vivek Javli. And for the next lecture, I would like to invite Dr. Darshan Bankar. He is Chairman, Managing Director and Consultant Interventional Cardiologist, Bankers Group of Hospital, to give his talk on Every Patient Deserves the Best. To chair the session, I would like to invite Dr. Vasant Patel, Dr. Kakusha, and Dr. Ashok Shah. There is slight change in the schedule. After this, we'll have a short break, and the next lecture will be taken as surgical strike by Dr. Vipul Waghela, post-lunch.
To introduce Darshan, looking to this CV, I can't read too much. I put only 2 sentences. He's a visionary. Not only visionary, but executor. Many people are visionaries, but they don't execute. He's having some dreams. He visualizes it and then put in actions as such. For whom? For everybody. For patients, for a medical fraternity, and for science. Science is at heart, as well as patient is at heart, because he is heart specialist. I believe the topic which he has selected is a holistic topic. Patient is at heart, not heart is the center. So I believe he will deliver the goods in this spirit as such. Dr. Darshan Bankar.
Good afternoon, and on behalf of Bankers Group, I welcome you all. It's been pleasure to carry on the same thing again and again. And by repetition, we become better. That's what I feel, in organizing as well as in learning also. So the same thing is happening with same speakers, same audience, and same hall for last 15 years. Nothing has changed, but in spite of that, we get people and we get everybody to learn the same things again and again. So that's something which we don't still understand, that we don't even change topics much. We don't even change our brochures nowadays. So our efforts are much lesser, and still we are so much enthusiastic about carrying out the same activity every year. this is not an academic lecture. Let me make it very clear. This is something which we are doing, and a huge thing which is going on around us nowadays. And I'm just going to give you the glimpses of what we are doing as of now. And we started with 22-bedded hospital in 2004 with 45 employees. That's what Bankers Heart Institute was. And journey so far is most of you, I would say, are the witness to it, are contributing to it, and are part of it. So 22 beds to 5 hospitals, 400 beds, and 850 plus employees. That's what we are achieving. We are going bigger and bigger. Well, our mission has changed from excellence in comprehensive cardiac care to comprehensive health care, with the, change in attitude of the governments and especially our honorable Prime Minister. We need to change, but still we are working with innovative technologies, and we try to do whatever best possible with us. This is the 5th hospital recently inaugurated, one of the state-of-the-art hospitals, and all groups of patients are treated without any compromise on quality of care, whether it is self-paid, corporate group, Mayodhana, or insurance. That is what we are looking at. No patient should be discriminated and will not be discriminated at Bankers. That is how we are looking at patients. I mean, patient doesn't know what is happening, but in general, we will see that everybody is given the same treatment. Facilities may be different, but the treatment and care would be the same for everybody. And many more to come for Bankers. We started with obviously various cath labs, which is there with us. What we do in cath lab is amazing of late. We know we have almost reached 6,000 procedures per year in cath lab now. More than 3,000 angioplasties this year, which is an amazing number for a single group to carry out such a huge number, which is one of the largest in the country and the largest obviously in Gujarat. It's the largest number in Gujarat, there is no question about it. And we have been doing huge amount of primary angioplasties, and we have a door to balloon time of 72 minutes. As of now, as I'm talking, we have already done 2 primary angioplasties in the morning. So that's what Bankers is all about. And most of you who are referring patients knows that when patient reaches Bankers, within 20 or 30 minutes, primary angioplasty is done and always done. And that is the level of confidence we have given to the society, and that is what is carrying us. And obviously, we are complying with international standards for the same. We have been doing various newer technologies like live stent boost during stenting. Does all stenosis require stenting? Because we all know that there is a lot of things which goes around stenting, and it is not only visual now, it is more of physiological also, and we are carrying out that by physiological assessment in a lot of patients by doing FFR, and whenever required we do. I was in many of these patients. Bhavesh has already mentioned the imaging has become more advanced in cardiology, and we are using it, and we are the first people to have intravascular ultrasound in Baroda. Now we have been training others also for intravascular ultrasound, and it has been our great, we have a IFFR, which is an intelligent FFR, which is being used quite often. I mean, a lot of patients undergo this when we are not sure whether we need to do an angioplasty or not. Beyond coronaries, we were the first one here to do TAVI in Baroda. We have done 3 TAVI last year, and we are trying to develop this program in next 1 or 2 years. And you'll be surprised to know that TAVI is done in all 3 patients. One of them was doctor himself, one of them was a US cardiac surgeon's mother, and the 3rd patient is a doctor's neighbor. So most of the time TAVI is a procedure which is being carried out in a vicinity of doctors only as of now. And we were the first to put in fact, not Vadodara's, Gujarat first leadless pacemaker was put by Bankers. non-invasive cardiology. You heard about strain imaging. We are the pioneers in strain imaging, and we have been doing this for last 6 months now for a lot of people, and we have started, this is a very new modality which is coming up, 3D strain imaging, and we are the only one acquiring this technology in Gujarat of 3D strain imaging. So this is what is, it is still a research tool, but to work on research tool also is a big thing, and we are doing that. And obviously 3D echo guided, that is not 3D echo, it is a 3D transesophageal guided ASD device closure has become a routine in bankers, and a lot of people know. I'm sending them videos and the way we do it in cath lab for that thing. So we are not only cath lab people, we have OT, which is one of the largest center for doing cardiac surgery as of now in Gujarat. In fact, in private, we are the largest now, I suppose. We have done this year 900 cardiac surgeries, which is one of the largest number in Gujarat. And Vipul, Sandeep, and Devang, all three are working very hard, and they have been doing extremely big number for this thing. Well, that's okay. Yeah, but okay. It's not coming. I'm sorry, there is some. So this is more than 800 and actually 852 cardiac surgery done this year, which is a very, very large number, almost 3 per day, even if you include Sundays. And apart from numbers, we have been, why this number has come? It has not come like that, because we are giving so much of patient care, and it's a real buzz for us to have one of the finest code blue team. In fact, many of the other hospitals are told by NABH that if you want to learn code blue, go to bankers. This is what has happened, that if you actually want to learn code blue, go to bankers, how the code blue is being done. And we have a dedicated team, and there is a huge response to it. I'm just going through one of the very small, simple thing which happens in bankers for nursing care, which all these things matters to us very much, like maintaining PIVA, the VIP score for a peripheral venous line. Okay, now this is something which is very basic thing, but if you do such things, you do so much for patient from morbidity point of view, from patient comfort point of view. So this is regularly done for all patients across the board. And this is how we evaluate PIVA also, that whether we have done properly or not. We carry out regular check on thrombophlebitis incidence in all hospitals and find out how it has worked for us and who has made the mistakes, or where we need to make more efforts so that we don't have more thrombophlebitis. So this is one of the point of doing a nursing care also at various level. So this is how we carry out that thing. We are the first one and only one in Baroda to have ECMO machine of our own, and we are very happy that we have saved patients on ECMO. Actually, one of the patients stayed for almost 40 days on ECMO with a swine flu and came out. This is what his X-ray is, pre and post. So that was one of the patient which we saved. We maintain stringent SOPs. Our one hospital has already been NABH accredited. The another one is almost there, and the third one is in the process of NABH accreditation as well. Education has also been a part, an integral part of bankers. We are running a very active DNB program, and I'm very proud to say that we got the DNB, you know, it's a national exam, and you will be, I mean, in Gujarat or all over India, 4,000 people appear for DNB cardiology and DNB for multi-speciality, all specialties, I would say. And bankers was filled at a rank of 80. So that itself shows that we have a big training program, and we are very proud of that. We have a clinical cardiology fellowship program also. We have a big nursing institute. Every year we train almost 100 nurses at this institute. And we have a medical technical education for various courses are being carried out in our educational place. And obviously, you know, we carry out huge amount of CMAs all throughout. We have a journal club, and we have training programs. Apart from education, since society has given so much to us in last 15 years, we always think that we need to pay back to society. And where we come is our CSR activities. And obviously, this year, Parul has taken over this project of Dil Se CSR, which is a very huge project which we are carrying out now, is to train people for CPR, train normal people, train paramedics, train policemen, train railway employees for CPR. This is what we are looking at, and we want to have maximum number of people trained for basic CPR with us. And part of that we have already started. We carry out a lot of heart checkup camps. As you know, we do a lot of heart and health exhibitions across we carry out school quizzes for the people. And we are very proud to say that we have installed the first AED machine on any of the railway stations in India is at Vadodara. So first AED was installed, and we have a TV running how to use it also. So that's something which we have done for the first time. We have various CPR training courses. We have a road beautification programs. We have Diwali celebrations with underprivileged. We are sponsoring 10 Anganwadis all throughout the years in city of Vadodara. That's our. We are running a very active public library for senior citizens in Baroda. And for all these activities, we have received various awards for quality cardiac care, for Swachhta Award, for True Impact Award for social activities, CSR awards. She has received a Woman Entrepreneur 2014 award. Parul has received that. And I can't forget my team who works day and night to put all these things in real place. And 2 roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. I thank you all, and thank my parents especially for whatever we are. Thank you very much. I'll just take 2 minutes to acknowledge my people who have worked extremely hard and has been part of our team for very long time. Those who get associated with bankers, usually we are like glue. We don't let them leave our place. Dr. Vipul Waghela, he has been the backbone for cardiac surgery at bankers. Dr. Manoj Subramaniam, not available today. He is running somewhere, not somewhere in Mumbai. Dr. Sandeep Soman, or another cardiac surgeon. Dr. Devang Nayak is operating in Surat just now. Dr. Sonal, she is our another cardiac anesthetist. And cardiologist team, Dr. Rajat Ghadi, Dr. Suanka Ghosh, Dr. Sagar Kabde, Dr. Pawan, Dr. Ronak Ruparelia, our new addition, Dr. Mayur Chaudhary, and my DNB registrars, Dr. Danish, Dr. Mahesh, Dr. Ronak Modi, Dr. Rajanya, and we have PGTCC registrar Waris Ali and Kamrul Islam. I think they are still on duty. My intensivist team, they are the people who are behind in ICUs taking care of all critical patients, because the cardiologists give them sometimes bad patients, but still they work very hard for that. Dr. Udgit Thakur, Dr. Puneet Getia, Dr. Akash Chawda, and our whole team of doctors, which will be like Dr. Bijal Patel. She has been the backbone for managing all the doctors. Now we have addition of various doctors in our team. One of them is Dr. Hardik Gajera, nephrologist, and Dr. Mehul Singh, urologist. Our team at Surat is Anupam Mahrotra, he is a cardiologist, Nilesh Katheria, Devang Nayak, Amar Panchal is an anesthetist. We have an intensivist, Richa Khandelwal, Mahindra Rawal, and the backbone of that team is Dr. Vismay. So I thank all doctors for that. And last but not the least, the people who help us to carry out this CME, not only today, but all throughout the year, they are always there to help us out, is Torrent Pharmaceuticals, Sun Pharma, Aprica, US Vitamins, AstraZeneca, Novartis, Abbott Vascular, Abbott Healthcare, Medtronics, Aris Pharmaceuticals, St. Jude, and Surgeon Ledgers. I thank you all for attending, and we will have lunch, and then we will have a very, very interesting sessions coming up, like another quiz, which is going to be a basic quiz on ECG, very basic. What you have seen was something where you learn a lot of things, and this will give you huge amount of insight into the basic ECG training as well. You will have surgical strikes, and then we have devices, which device to use from Ashish Nabar, and very interesting cases which we have collected from thousands of patients. And some of them are really, in fact, when I saw, I also realized that what kind of work we are doing. So after lunch we meet. Thank you very much. Thank you.
Thank you, sir. We'll depart for lunch, but as we are running 10-15 minutes behind the schedule, we'll start academic program sharp at 2:30. So as soon as the lunch is finished, please gather again in the auditorium, please.
Great. Great.
जो ठीक होते हैं वैसे, जो कोई सीरियस प्रॉब्लम नहीं होता,
ये सरनच है।
सडनली अस्पताल में नहीं होती, लेकिन घर पे या रास्ते पे या कोई अपने काम पे या थिएटर में, कोई शॉपिंग में, वहां होती है, पब्लिक प्लेसेस में। यहाँ इंडिया में, भारत में अब तक ऐसे कार्डियक अरेस्ट, गहलोत जी ने बताया कि किसने तो भी सेव किया। रिसेंटली मैं अपनी 30-25 साल जो हार्ट का प्रैक्टिस कर रहा हूं, उसमें मैं ऐसे 2 या 3 उदाहरण दे सकता हूं कि ऐसे लोग को बचाया गया, और हजारों ऐसे उदाहरण दे सकता हूं जहां नहीं बचाया गया। कल बंबई में 28 साल के उम्र का लड़का जिम में बेंच प्रेस कर रहा था। बेंच प्रेस करने के टाइम कोलैप्स हो गया। जिम के ट्रेनर्स, जिम के आजू बाजू लोग ने क्या किया? वो जो जानते थे वो किया। वो क्या जानते थे? किसने कहा कि भाई इसको चप्पल सूंघाओ, और किसने कहा डॉक्टर को बुलाओ, और तीसरे ने कहा उसको उठा के हॉस्पिटल लेके जाओ। फाइनली वो उसको उठा के चप्पल सूंघाया, कुछ नहीं हुआ, डॉक्टर कोई तुरंत नहीं आ सका, उसको उठा के अस्पताल ले गया। 28 साल का आदमी, अस्पताल पहुंचते तक तो वो मर गया था। ये आदमी को बचाया जा सकता था अगर उनको जानकारी होती कि क्या करना चाहिए, और ये जानकारी देने के लिए ये प्रोग्राम आज किया गया है। और वो मुश्किल नहीं है उसको जान बचाना। 3 दिन पहले 70 साल के आदमी बांद्रा में चल रहे थे, चलते चलते कोलैप्स हो गए। उसके पीछे एक आदमी ने देखा, समीर फरिश्ता उनका नाम था, जिनको पता था क्या करना चाहिए, क्योंकि उन्होंने ये ट्रेनिंग अटेंड की थी। उन्होंने देखा कोलैप्स हो गए, रास्ते पे देखा सांस नहीं ले रहे, उनको पता चला ये कार्डियक अरेस्ट यानी हार्ट बंद पड़ गया है। उन्होंने मसाज चालू किया, आजू बाजू के लोगों इकट्ठे हो गए, कोई कहता चप्पल सूंघाओ, क्या कर रहे हो? उनको कहा, उन्होंने कहा मुझे पता है क्या करना है। और किसका कहा कि देखो मैं क्या कर रहा हूं। वो दोनों ने मिलकर मसाज दिया। तीसरा आदमी जाके भागा, बाजू के जो ऑटर्स क्लब बोलते हैं वहां ऐसे शॉक का मशीन था, वो मशीन लाए, 1 शॉक दिया, 2 शॉक दिया, आदमी की सांस चालू हो गई, हार्ट चालू हो गया, होश में आ गया। आज वो आदमी चलता फिरता है। तो 2 दिन पहले बस चलाते हुए बस ड्राइवर बॉम्बे में, 45 साल का आदमी बस ड्राइवर, बस रुकाया, छाती में दर्द हुआ, कोलैप्स हो गया। बस में कंडक्टर या किसी को कोई नहीं मालूम था क्या करना है। वही गाड़ी रिक्शा में लिए अस्पताल लेके गए, पहुंचते पहुंचते डेड। 1 मिनट में जब कार्डियक अरेस्ट होता है तो अपने पास सिर्फ 10 मिनट है जान बचाने के लिए, और हर मिनट में 10% चांस कम है। यानी 1 मिनट में आपने मसाज चालू किया तो 90% चांस है कि बच सकता है। 2 मिनट 80% चांस, ऐसे 10 मिनट हो गए तो 0% चांस है कि आदमी बच सकता। इसलिए ये उठा के लेके जाने का जो अपने इसमें है, हाँ भले उसको लीजिए एम्बुलेंस में, कार में, रिक्शा में, लेकिन मसाज चालू रखिए। ये मसाज चालू रखेंगे तो आदमी बच सकता है। दुनिया के कई शहर ऐसे हैं जहां कार्डियक अरेस्ट जो होते हैं अस्पताल के बाहर 50% लोग बचाए जाते हैं, 50% लोग। इंडिया में 1% भी नहीं बचे। और यूजुअली ज्यादातर ये लोग की उम्र होती है बहुत ओल्ड नहीं होते, 80-90 साल के नहीं होते, 30, 40 और 50 ये एज ग्रुप सबसे ज्यादा है जिसमें कार्डियक अरेस्ट होता है। तो अभी 10 मिनट में हम बताएंगे कि आप क्या कर सकते हैं। नेक्स्ट स्लाइड। कार्डियक अरेस्ट यानी हार्ट अरेस्ट क्या होता है? कि दिल सडनली धड़कना बंद कर देता है। ये होता है तब दिमाग को खून नहीं पहुंचता, ऑक्सीजन नहीं पहुंचता, बेहोश हो जाता, सांस लेना बंद हो जाता। और ये क्यों होता है? बहुत लोग बोलते हैं हार्ट अटैक क्या है और कार्डियक अरेस्ट क्या है। कार्डियक अरेस्ट यानी हार्ट बंद हो जाता। हार्ट अटैक यानी जो खून की नलियां हार्ट को सप्लाई करती है वो सिकुड़ जाती है, छाती में दर्द होता है, अटैक बोलते हैं। उसमें अपन अस्पताल ले जाते हैं और आगे की ट्रीटमेंट होती है। लेकिन ये हार्ट अटैक कई बार अस्पताल जाने का चांस ही नहीं मिलता और आदमी को कार्डियक अरेस्ट होता है। इसलिए हर हार्ट अटैक कार्डियक अरेस्ट नहीं है। और कार्डियक अरेस्ट हार्ट अटैक छोड़ के दूसरे भी कोई वजहों से हो सकता है, लेकिन उसका मोस्ट इंपॉर्टेंट है हार्ट अटैक या तो अभी हुआ है या तो पुराना अटैक हुआ है, उससे कार्डियक अरेस्ट होता है। कोई कोई लोगों का हार्ट का मसल ही कमजोर होता है, उनको भी कार्डियक अरेस्ट हो सकता है। नेक्स्ट तो तीन चीज होती है जब कार्डियक अरेस्ट होता है। आदमी कोलैप्स हो जाएगा, आदमी औरत जो भी है कोलैप्स हो जाएंगे, फिर उनकी नाड़ी बंद हो जाएगी और सांस लेना बंद हो जाएगा। ये तीन चीज होती है। नेक्स्ट तो जैसे हमने कहा कार्डियक अरेस्ट किस वजह से होता है, सबसे कॉमन तो है हार्ट अटैक, और दूसरे भी कोई बीमारियां हैं, कोई कभी कभी छोटी छोटी उम्र में भी कोई हार्ट का रिदम अबनॉर्मलिटी से कार्डियक अरेस्ट हो सकता है। अच्छा, बेहोश होने के दूसरे वजह भी होते हैं, सिर्फ कार्डियक अरेस्ट नहीं, कॉमन। अपन सब यहाँ इतने लोग हैं, इनमें से हाथ ऊपर कीजिए जो जिंदगी में कभी एक आध बार भी बेहोश हुए, हाथ ऊपर कीजिए। कोई है जो बेहोश हुए हैं कभी? नहीं, कोई नहीं है ना? मैं भी बेहोश हुआ हूं एक बार। 60 की उम्र तक प्रतिशत 50% लोग जिंदगी में कभी तो बेहोश हुए होंगे। ये कॉमन होता है, ये बेहोश हो जाते हैं, तुरंत होश आ जाते हैं। कभी कोई लोगों को एपिलेप्सी की बीमारी होती है, फिट की, उसमें भी बेहोश हो सकते हैं। कभी कभी ब्लड शुगर डायबिटीज पेशेंट में एकदम कम हो जाता है, उसमें भी बेहोश हो सकता है। तो बेहोश होने के अनेक कारक है, ब्रेन में ब्लीडिंग हो गया तो बेहोश हो सकता है, लेकिन ये सब में सांस चालू रहती है। कार्डियक अरेस्ट सिर्फ एक चीज है जो बेहोश होने के साथ साथ सांस बंद हो जाती है। आप 10 सेकंड के लिए रुको, 10 सेकंड में बिल्कुल सांस नहीं आई, यानी ये कार्डियक अरेस्ट है। और ये देखिए, एक बार कार्डियक अरेस्ट हुआ तो अपने पास कितनी समय है कुछ करने को? 10 मिनट में ब्रेन का इतना डैमेज हो जाता है कि उसके बाद इवन अगर आपने हार्ट को चालू किया तो पेशेंट या तो होश में नहीं आएगा, या अगर होश में भी कभी आया तो कभी कुछ कर नहीं सकेगा, ब्रेन को कंप्लीट डैमेज हो जाएगा। तो हम क्या कर सकते हैं आज ये दिखाने वाले हैं। और पुलिस का रोल बहुत इंपॉर्टेंट है, जैसे गहलोत जी ने कहा। रेलवे स्टाफ, जैसे बंबई में हम देखेंगे तो एयरपोर्ट पे, इंटरनेशनल एयरपोर्ट पे ऐसे 50 मशीन है, 50, और एक दो जान भी बची है। रेलवे स्टेशन पे ऐसा एक भी मशीन नहीं। और कितने ज्यादा लोग बड़ौदा में है, वेरी गुड, क्योंकि एयरपोर्ट के सामने कितने और लोग रेलवे से जाते हैं और कितने कार्डियक अरेस्ट बॉम्बे के लोकल प्लेटफॉर्म पे होते हैं। तो हम जैसे पुलिस को ट्रेनिंग दे रहे हैं स्टेप बाय स्टेप, ये बड़ा टास्क है। वैसे हर रेलवे स्टेशन को, और हमारे साथ जो डॉक्टर रेड्डी हैं रेलवे के कार्डियोलॉजिस्ट, रेलवे के कोऑपरेशन से पूरा रेलवे प्रोटेक्शन फोर्स को हमने लास्ट टाइम ट्रेन किया है इसमें। तो होपफुली उम्मीद है कि आगे जाके जान बचेगी। और तो दो चीज होती है इसमें, एक मसाज देना और दूसरा शॉक का मशीन यूज कर। तो मसाज कैसे दिया जाता है अभी हम दिखाएंगे इधर कैसे करने का। फर्स्ट थिंग, अगर कोई कोलैप्स हो गया तो सेफ्टी, 3 का सेफ्टी, यानी अगर रास्ते पे है तो जरा साइड पे ले लेना है, तो पहले सीन सेफ करना है, और फिर देखना है रिस्पॉन्स। जैसे दिखाते हैं, सपोज ये कोलैप्स हो गए, ये व्यक्ति को कार्डियक अरेस्ट हो गया, कोलैप्स हो गया, और आपने देखा कि कोलैप्स है, तो फर्स्ट चीज 3-4 बार कंधे पे करके, आप कैसे हैं, आप कैसे हैं, आप कैसी हैं, हेलो हेलो, ठीक हो क्या, 3-4 बार ये बोलिए। अगर कॉमन फेंटिंग है, जो हमने बोला, जैसे अपन कभी कोई एकदम भूखा फेंट हो जाता है, या किसको सडनली कुछ खून देखते हैं, खून का साइट या कोई स्मेल, फेंट हो जाते हैं, तो ऐसे किया तो थोड़ा थोड़ा रिस्पॉन्स देंगे। अगर रिस्पॉन्स नहीं है तो इमीडिएटली हेल्प, आजू बाजू किसको बोलो, भागो, किसको बुलाओ और 2-3 लोगों को बुलाओ हेल्प करने के लिए। तीसरा स्टेप, सांस है कि नहीं ये देखना है। तो सांस है कि नहीं ये किस तरह देखना है, सिर्फ 10 सेकंड देखते रहेंगे। हाथ यहां रखना हल्की तरह से, कुछ मूवमेंट होगा तो सांस है, कुछ मूवमेंट नहीं होगा तो सांस नहीं है। तो छाती की मूवमेंट देख सकते और साथ साथ में खाली पेट पे हाथ रख के देख सकते कि सांस 10 सेकंड देखो हिल रहा है कि नहीं, 10 सेकंड देखो सांस आ रही है कि नहीं। 15-20 सेकंड में पता चल जाएगा कोई रिस्पांस नहीं है, कोई सांस नहीं है, ये और कुछ नहीं है, ये है कार्डियक अरेस्ट। और जैसे ही पता चला ये कार्डियक अरेस्ट है तो फिर इमीडिएटली तुरंत किसको बोलो, कोई क्लोजेस्ट एम्बुलेंस या हॉस्पिटल बुलाओ। अगर ऐसे मशीन है आजू बाजू, जैसे हम उम्मीद है हर बॉम्बे के पुलिस स्टेशन पे, हेल्थ क्लब पे, नर्सिंग होम्स पे ये होगा, बड़ौदा में भी अभी नहीं तो 5 साल 10 साल के बाद ये होगा। तो ये इसके लिए एक भगाओ किसको लाने को, और तुरंत चेस्ट कंप्रेशन या हार्ट मसाज चालू करो। दोनों हाथ, आप दोनों हाथ रखिए ऐसे, दिखा रहे हैं ऐसे कीजिए सब, कंधे सीधे, ये यहां से सीधा, हाथ सीधा, एक के ऊपर एक हाथ रखिए और you'll have to do it with down। यूजुअली ये नीचे होगे, टेबल नहीं होगा, तो आपको जमीन पे करना पड़ेगा, ये आसान नहीं है। इसलिए हट्टा कट्टा आदमी भी मिनट में 1 या 2 मिनट कर सकेगा सबसे ज्यादा। ये जो छाती का बीच का भाग है, बीच का भाग, ये हड्डी, यहां मसाज देना है और ये हड्डी को 2 इंच दबाना है, 2 इंच दबाना है। ये आपको बाद में एक एक करके दिखाएंगे। तो ये इस तरह से होगा, दाहिने तरफ तो अरेस्ट हो गया, उनके दाहिने तरफ ये हड्डी, ये जो है भाग बीच पे रखना है। आप लोग सब भी बैठ जाइए तो आपका है, फिर बाद में फिर से करेंगे। आप लोग बैठ, हाँ देखो मैडम कैसे बैठे हैं वैसे नील करके, इसलिए ये बूढ़े लोगों का काम की बात नहीं है। ये हाथ ऐसे रखिए और यहां से दबाना है, यहां से दबाना है। कितना मिनट में? 100 बार। डू वी हैव द म्यूजिक? नो, 100 बार। 1 2 3 4 5 6 7 8 9 10 करते जाइए। 2-2 इंच, 2-2 इंच नहीं, आप बहुत फास्ट कर रहे हैं। देखिए मैं फिर से बोल रहा हूं, मैं बोल रहा हूं वैसे कीजिए। 1 2 3 4 5 6 7 8 9 10 11 12 13। अभी आप सोच सकते हैं, ठीक है रुक जाइए, आप सोच सकते हैं आप ये डमी पे कर रहे हैं। जो आदमी होगा उसका इतना फ्लेक्सिबल चेस्ट नहीं होगा, कोई कोई हट्टे कट्टे होंगे। ये 2 इंच दबाना पड़ता है, आसान नहीं है। कभी कभी ये करते हुए थोड़ी हड्डियों की इंजरी भी हो सकती है, रिब की, जैसे वहां लिखा गया है, रिब में क्रैक भी हो सकता है। रुकिए मत, बीच में करेंगे, बीच में मिनट में 100 बार। ये करते करते आजू बाजू वाले को बोलना है। अगर आजू बाजू वाले इकट्ठे हो गए हैं, जिनको मालूम नहीं है, इसमें से किसको मालूम है तो ठीक है, आप 1 मिनट करेंगे, दूसरे 1 मिनट करेंगे, आप 1 मिनट करेंगे, क्योंकि ये और लंबा करना मुश्किल है, थक जाएंगे। अगर और कोई नहीं आजू बाजू जिसको आता है कार्डियक मसाज, तो उनको बोलिए मैं कर रहा हूं या मैं कर रही हूं, आप देखिए मुझे, क्योंकि 1 मिनट के बाद आपको करना है। समझे? कम से कम 2 आदमी चाहिए। ये कार्डियक मसाज में आदमी को 20 मिनट तक जिंदा रख सकते हैं, 20 मिनट तक जिंदा रख सकते हैं। और 20 मिनट यानी दो लोग 10-10 मिनट, 1-1 मिनट करते करते टोटल 10-10 मिनट करेंगे। इसको बोलते हैं कार्डियक मसाज। अच्छा, 2 चीज ध्यान रखिए। आपने देखा होगा, मैंने कहा नाड़ी चेक करने की जरूरत नहीं है, तो नाड़ी चेक करने में टाइम मत वेस्ट कीजिए, खाली सांस दे। और दूसरा, मुंह से मुंह जो सांस देते थे वो भी देने की जरूरत नहीं है, क्योंकि जब भी हम छाती को दबाते हैं और छोड़ते हैं तो अपने आप को फेफड़े में हवा आती है। देखो सर भी कर रहे हैं। और बरोबर कर रहे हैं, एकदम बीच में, मिनट में 100. इट इज नॉट इजी, इट इज नॉट इजी. ओके. और उसके बाद जब ये मशीन आ गया, जब ये मशीन जैसे ही आ गया तो तुरंत मशीन कैसे, बाद में हम दिखाएंगे फिर से, लेकिन दिखाइए कैसे. यू शो इट नाउ सुमया. ये मशीन निकाला तो उसमें ऑटोमेटिक, आनंद, या देखो खोल रहे हैं मशीन, ना लिखा है पुल, पुल गया. उसमें निकलेंगे, अलग अलग टाइप के मशीन होते हैं लेकिन सब सेम. ये पैड निकाले, ये पैड निकाले, ये पैड को छाती पे लगाएं. वहां दिखाया है, वहां पिक्चर भी है कैसे लगाना है. एक ये साइड पे और एक ये साइड, 2 पैड लगा दिए आप. 2 और मशीन और बोलता है लेकिन इंग्लिश में है, लेकिन अभी हिंदी में और दूसरे लैंग्वेजेस में भी आएगा. एक बार लगा दिया तो क्या बोल रहा है, अभी पेशेंट को कोई हाथ मत लगाओ. मशीन जो बोल रहा हूं मैं जोर से बोल रहा हूं, कोई पेशेंट को हाथ मत लगाओ. अभी बोल रहा है मशीन में देख रहा हूं कि कार्डियक अरेस्ट है कि नहीं, तो मशीन देख रहा है, कोई हाथ मत लगाइए. शॉक एडवाइस बोलते हैं शॉक दीजिए, ये लाल बटन दबाइए, तो आपको लाल बटन दबाना है. दिया, लाल बटन दबाया. तो क्या है, ये मशीन सब अपने को बोलता है, इसलिए ऑटोमेटिक नहीं देगा. जब तक आप नहीं दबाएंगे तब तक शॉक नहीं मिलेगा. इसलिए इसको बोलते हैं AED, ऑटोमेटिक एक्सटर्नल डिफिब्रिलेटर. फिर वापस देखेगा मशीन शॉक देने के बाद.
No one should touch the patient. Analyzing.
देख रहा है, मशीन चेक कर रहा है.
No one should touch the patient.
कोई हाथ मत लगाइए.
Analyzing. Shock advised. Stay
शॉक
clear of
कीजिए,
patient.
सब लोग दूर.
Press
हाथ
the
मत लगाइए.
flashing orange button now.
ये लाल बटन को दबाइए.
Shock now. Shock delivered.
शॉक दे दिया.
Be sure the ambulance service has been called.
एम्बुलेंस को बुला दीजिए.
It is safe to touch the patient.
अभी पेशेंट को हाथ लगा सकते
Start
हैं.
CPR. For help with
मसाज
CPR,
चालू कीजिए फिर से.
press the flashing
कभी एक शॉक नहीं, 2-3 शॉक भी देने पड़ते. तो मशीन हर बार रिदम देखेगा. अगर रिदम आ गई है, पेशेंट का हार्ट चालू हो गया है, तो बोलेगा शॉक की अभी जरूरत नहीं है. या उसको लगता है कार्डियक अरेस्ट ही नहीं है, तो बोलेगा कि शॉक की जरूरत नहीं है. इसलिए ये काफी सेफ है, इसमें कोई प्रॉब्लम नहीं है. ये मशीन डॉक्टरों के और नर्सिस के लिए नहीं बनाया गया है, ये मशीन आम जनता के लिए बनाया गया है. तो आपने कभी भी जिंदगी में यूज नहीं किया होगा, तो भी पहली बार करेंगे तो कोई प्रॉब्लम नहीं है, क्योंकि उस पर चित्र होता है. ये पैड कहाँ लगाना है, ऐसे चित्र पे भी दिखाया गया है. ये पैड यहां लगाइए, ये पैड यहां लगाइए. तो कुछ आपको सोचने की, खुद की सोचने की जरूरत नहीं है. बहुत लोग घबराते हैं कि हम कैसे मशीन इस्तेमाल करें. ये मशीन आम जनता के लिए है. ये मशीन डॉक्टरों सिर्फ के लिए नहीं है. ओके. अगर नेक्स्ट स्लाइड, नेक्स्ट. तो ठीक है, तो ये कुछ सवाल है आपको इस पे. Should we enter in questions now? हाँ, एक नो वीडियो एक आप 90 सेकंड की वीडियो देख लीजिए जो हमने खुद बनाई है. कैन वी प्ले द वीडियो? या किसको सवाल है तो प्लीज पूछिए, क्योंकि आप शायद दूसरों के भी होंगे और वो उनके डाउट होंगे. तो वी हैव अ माइक ऑडियंस. हाँ, शॉक कितनी बार देना है? यूजुअली 1, 2 या 3 शॉक में अगर रिवाइव होता है तो हो जाता है. लेकिन कभी कभी अस्पताल में हमने 15-20 शॉक भी दिए हैं. मैंने खुद दिए हैं पेशेंट को 20 शॉक और पेशेंट रिवाइव हुआ. लेकिन 2 शॉक के बीच में मसाज चालू रखो. और कोई सवाल? ये देखते हैं. आनंद, यू हैव टू मूव फ्रॉम द. और कोई सवाल है? हाँ, ये देखते हैं. सबको दिख रहा है स्क्रीन?
याद है हम लोग उस दिन शादी में गए थे, करा देना सुनीता, कल सेम कॉस्ट्यूम ना मुझे भी अपने लिए चाहिए। अंकल याद है आपको मैंने बोला था? अंकल 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 प्लीज हेल्प मी प्लीज प्लीज हेल्प मी। माय गॉड चलो 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 अंकल प्लीज आप एम्बुलेंस को कॉल करेंगे।
जैसे आपने देखा कि इसमें अगर जान बचानी है किसकी तो जान आप बचाएंगे। अस्पताल या डॉक्टर या वो आगे का ट्रीटमेंट देख सकते हैं, एक बार जान बची है उसके बाद। तो प्लीज ये गलती मत करना कि कुछ नहीं करते हुए राह देखते रहें, क्योंकि जान बचानी है तो दुनिया में सब जगह देखा गया है जहां कार्डियक अरेस्ट से जान बचाई है 90% केस में आम जनता के कोई आदमी या औरतें जान बचाई, आम जनता की। ओके, दैट इज वेरी इंपॉर्टेंट।
What we will do is, હવે આપણે એવું કરીએ, હવે બધાને આવડી ગયું છે રાઈટ? બધાને ફાવશે ને? તો આપણે સ્ટાર્ટ કરીને એકવાર જોઈ લઈએ કોણ 2 મિનિટ સુધી કરી શકે છે. ચલો હવે આપણે તમે બધા કરો, અમે લોકો જોઈએ છીએ કે તમે બરાબર કરો છો કે નહીં, રાઈટ?
તો કાર્ડિયક મસાજ હવે ચાલુ કરજો, અમે કાઉન્ટ કરીએ છીએ. વી ડોન્ટ હેવ ધ મ્યુઝિક. एक्चुअली कोई बार कोई म्यूजिक ट्यून ની પ્રમાણે પણ જોઈ શકે તમને. યુ કેન પ્લે ઇટ. અમે જે ટ્યુન વગાડીએ છીએ મશીનમાંથી એ સ્પીડ પર જવાનું, નહીં તો હિન્દીમાં એક ગાયન છે દિલ ધડક ધડક કે કહ રહા એ આ બીજા, એ સ્પીડ પર જશો તો 100 થશે મિનિટમાં. પણ અમે જસ્ટ ટુ હેલ્પ યુ
Stay clear of patient shock to delivery. Be sure the ambulance service has been called. It is safe to touch the patient. Start CPR. For help with CPR, press the flashing blue button. Place the heel of one hand in the center of the chest,
Ready?
in the nipple.
હવે ચાલુ
Place
થશે
your other
મ્યુઝિક.
hand on top of the first. Push chest down firmly 5 centimeters.
ચાલુ.
Time with the beat.
દર વખતે અવાજ આવે 2 ઇંચ જવાનું છે. તમે બરોબર નથી કરતા. 2 ઇંચ.
Pinch nose. Tilt head. Lift chin and give. Like that. No one should touch the patient.
બસ છોડી દો પેશન્ટ.
Analyze.
હવે કે છે શોક આપવાના છે.
No one should touch the patient. Analyze. Shock advised. Stay.
ઓકે, હવે આ તો હવે અમે આ શોક મશીન અમારા વોલેન્ટિયર્સ સુમૈયા અને આનંદ લાવશે કે તમે બધા પ્રેક્ટિસ કરશો શોક મશીન કેવી રીતે યુઝ કરવાનું છે. આનંદ, સુમૈયા, યુ લીડ ધ મેનિક્વિન or they can come here.
Hello, hello. We are starting the session in next 2 minutes. We are just waiting for few more people to join us. Within 2-3 minutes, we are making announcements outside that we are starting the session. We'll start with Dr. Ashish Nabar, followed by Dr. Vipul Waghela, Dr. Ronak Ruparelia, and then interesting cases by Dr. Ghosh and Dr. Pavan. પણ હવે આવતા નહીં બહારથી અંદર તો શું કરવાનું?
A very warm welcome to everyone on a beautiful Sunday afternoon post-lunch session. Meanwhile, everyone arrives from the lunch. We will have a short clinical question, an interactive session. This was a 24-year-old staff nurse who attended the emergency room with complaints of on and off palpitation and dyspnea since 4 days. Off lately, she had a stressful life owing to some personal issues at home. There is no history of chest pain. Family history not significant. There was no fever. Cardiac checkup done 1 year back was normal on a employment basis. Her ECG was as follows. Next. So this was our ECG. Next slide, please. So what would you expect on an angiogram? A thrombotic occlusion of LAD, thrombotic occlusion of RCA, severe triple vessel disease, or normal coronaries? Previous. ECG. So this was the ECG. Can we have a timer, please? You can please vote now. So there was almost similar answer of LAD versus normal coronaries. Let's see what happened to the patient. Patient was taken for angiogram. Angiography was normal. So LV angiogram was done, which showed next slide. So this was our LV angiogram. Can anyone tell what is this? DNB students. Yeah, it was Takotsubo cardiomyopathy. Particularly, as Dr. Yash Lokhandwala sir discussed, particularly occurs after stressful life, chest pain, ECG showed ST elevation, normal coronaries with this kind of picture. So this brings us to the next session, an interesting session on rhythm monitoring device to diagnose paroxysmal arrhythmias by Dr. Ashish Nabar sir. May I request all chairpersons, Dr. Kiran Shah, Dr. Thakur Bhai Parmar and Dr. Usman Ghani Khatri to come on the dais and introduce Dr. Ashish Nabar.
Good afternoon. I think everybody is ready for after lunch session. Okay. We are again going to start our scientific session. Now we are having a Dr. Ashish Nabar. He is a postgraduate from KEM Medical College, Mumbai. At present also he is a professor at KEM Medical College. He has done his electrophysiologist fellowship from Netherlands. And he is going to deliver a talk on rhythm monitoring devices to diagnose proximal arrhythmia. Over to Dr. Ashish Nabar.
Thank you very much for a very kind introduction. I think the lunch was obviously too good. The legs are moving a little slowly towards the auditorium, but these are the interested ones. And the few more will surely join us in some time. Around Navratri time, we are always waiting for that invitation from banker for last number of years, and I do know why it is this time in January. Parul is always playing a great host, so all of us from the erstwhile KEM guys are all too enthusiastic to come in Baroda. And Wajifdar Dr. Bhavesh Wajivdar creates a very, very interesting program that you are not here only to talk, but you also like to sit across and listen to what others want to say. So a very interesting program. Plus he gives you a choice as to what would you like to address, and I said paroxysmal arrhythmias is much to an under-recognized entity or undiagnosed entity. So let me talk about how best to use ambulatory ECG to diagnose these arrhythmias. Now, it's not only that you talk of ambulatory ECG for diagnosis, meaning if you have patients who have symptoms of syncope or palpitations, and elderly often, despite having an arrhythmia, don't always talk of palpitations, they talk of shortness of breath, and then you want to diagnose an arrhythmia. But these ambulatory ECG monitoring devices are also useful when you want to, when you have initiated the treatment and you want to assess how good the treatment is working, then also you will apply ambulatory ECG, something that is not easily recognized by everybody. And then you might also do, after putting a implantable device like a pacemaker or an ICD, to assess the prognosis or the working of the device. So an ambulatory ECG has a lot of use. Obviously, when you are going to use an ambulatory ECG device, you want it to be very small and portable, that can be wore for varying durations, say 48 hours, 24 hours, at times 7 days. Sometimes they're even implantable because they're very small. You want the whole ECG to be recorded, all the beats to be recorded, so you can have a good software algorithm to analyze those ECGs in a good way, and they should be recorded with a high fidelity, because with the movements of the chest wall there should not be noise generated. And if possible, they should online transfer that ECG data, so that any important diagnosis, for example, if you want to diagnose a non-sustained VT, you'd be happy to have it online so that there is immediately an alert raised about it. So the different devices fit in different ways, and you use depending on the question that you are asking which device you'd use. There are a number of these devices, but what you need to know presently is what is called as a Holter monitoring. So that is usually for 24 hours, but can be extended to up to 72 hours. And that's useful obviously when your symptoms are more than once a week. When your symptoms are less than once a week, then you would need a longer monitoring, and these are external loop recorders which can be put for 7 days. But if your arrhythmic event is very, very infrequent, like say once in 3 months, then you would need something like an implantable loop recorder. So today you need to understand how to use a Holter monitoring, how to use an external loop recorder, and how to use an internal loop recorder to be able to diagnose the paroxysmal arrhythmias. Actually, all of you are familiar with this Holter monitoring device, which uses your usual disposable electrodes. Most of you probably know that they record either 2-channel or 3-channel, but there are devices which record 12-channel, and the 12-channel recording is useful to localize the arrhythmia also, and I'll explain to you how that is. So remember that there are also 12-channel ECG recording Holters, and as you know, the Holter is always analyzed later after the patient comes back and gives that device. You put the flash card in your computer system and you analyze the rhythm on the workstation. So this is how actually there are more derived ECGs. So when you are recording a 12 lead ECG, you don't have to put 10 leads like when you're recording a ECG. There are 5 leads as are shown here, and through 5 leads you can have a derived 12 lead ECG. Philips particularly has this kind of a recording system, so it's sometimes useful to have a 12 lead ECG. For example, if somebody has a VT, then a 12 lead ECG will provide you an idea where the VT originates from, and that has significance clinically, prognostically, etiologically. So you would like to know more than what a 2 or a 3-channel Holter can deliver. I like Holters a little more than external loop recorders, which are for 7-day monitoring, because I myself can analyze the Holter on a workstation which is in my office, so that I give a report about which I am confident. These days, a lot of pharmaceuticals provide Holter analysis to the physicians, and I think it's a good service to expand the base of doing Holters, but I'm not sure who does the analysis. Many times these reports are even not signed by the person analyzing, so I'm pretty skeptic about using this. And I precisely like Holters because I can analyze them myself in my own office, so therefore I like Holters for that reason. But there are some difficulties with the Holters. The electrode gel leads can sometimes get detached, especially in summer months when the person sweats. So that would lead to loss of signal quality, or there could be artifacts. And you cannot in real time analyze. So for example, somebody has a Holter on and gets a non-sustained VT or a VT, you would know only the next day when you analyze the Holter, not online, and a fatal event might happen in that time. So these are certain limitations of Holter these days, but the fact that I can analyze beat to beat myself, of course the software algorithm helps me to do the work fast, but it gives me a confidence that I know what I am reporting. So there is the strength, therein lies the strength of a Holter. There is one more thing about the Holter, is that there is a particular button that can be pressed. So when a person has symptoms, the patient can press the button and indicate that it is at this time that he felt the symptoms, and then I can analyze at that time what exactly did he mean when he had the symptoms. Was the rhythm normal, or was there some paroxysmal atrial fibrillation, or what is he exactly meaning when he presses the button? So that's why Holter I find useful. But as I said, when the symptoms happen less often, then you need to monitor for a longer time, and you can't put these Holters for more than 48 to 72 hours. It's already clumsy. He can't take bath when the Holter is on. Plus, as the days progress, your electrodes are likely to become loose and you're likely to record artifacts. So you have something called an external loop recorder, which is a patch. That there are few vendors. Wipro is one of the vendor. So that patch is applied, and at the time of bath he can take it out and then again reapply the patch. So it allows you to monitor for 7 days, for example, or you can extend it depending on if you want to record for longer time. So obviously because of this, the patient acceptance is better. Not having bath is not a great idea. So patient acceptance is better. But it is usually a single channel recording, so therefore you cannot localize the arrhythmia based on the single channel. You may be able to record the arrhythmia, but you can't localize. And the difficulty with this external loop recorder is that the information is relayed online to a core lab, and then the core labs eventually generates a report. So you don't have control over all the analysis of the, but obviously you can't. I mean, 7-day analysis is impossible to do personally. So therefore the core lab sends you, and you have to rely on what the core lab sends. But the beauty is that you can record over longer lengths of time, and you can record the infrequent arrhythmias. If the patient is, for example, post-infarct having symptoms of giddiness and is likely to have a VT, then in that time of rehabilitation, sometimes they are given this telemetry. So there is a wireless communication. He has the ECG on, and there is a wireless communication at the workstation where while he is undergoing mobilization, if there is an arrhythmia, it can be recorded. Or sometimes if these patients come with a syncope and you think VT is at the back of it, then you probably admit and monitor him. So depending on how serious the symptom is, you use a Holter or a 7-day loop recorder, which is ambulatory, or you admit the patient and you monitor in the ICU, or use this mobile cardiac telemetry. Probably this is not yet so common with us. And then, as I said, there are arrhythmias which are still infrequent. For example, somebody has syncope once in 4 months and has a LBBB on the ECG, or has a sinus bradycardia and you suspect sinus node dysfunction. So it's not going to repeat probably very soon, and your Holters and 7-day loop recorders would suffer from negative reports more often. So therefore, when you know that the symptom is serious and definite, and you think of an arrhythmia etiology which is infrequent, then you do an implantable loop recorder. So this is a pen drive like device which is implanted on the chest wall through a very small incision, or some of them are such that they can be injected now under the skin. and it records the ECG continuously for next 18 months or so. Now, there is automatically it records heart rates. If you say everything below 50 should be recorded or everything above 150 heart rate should be recorded, then it helps you to record the brady and tachycardias automatically. Plus, there is a handheld device which you can keep on the monitor and you can record particular events when he feels giddy or when he feels palpitations. So it allows you monitoring for a long time and you are likely to increase the yield of the arrhythmia diagnosis. Here is what I mean. For example, the longer you monitor, the higher is the yield of an arrhythmia diagnosis, whether you are dealing with palpitations or syncope. The other important cause of arrhythmia monitoring today is cryptogenic stroke. When the neurologist doesn't find anything that could be possible in the carotids and your heart is structurally normal, but the guy is 65-year-olds with hypertension, the risk of atrial fibrillation causing stroke is high. And therefore, these days you proactively do rhythm monitoring in these patients because you don't anticoagulate a patient with stroke unless he has an atrial fibrillation. So there's a world of difference in why you want to diagnose atrial fibrillation in a stroke patient. So even in these cryptogenic strokes, the atrial fibrillation may be so infrequent, and the longer you monitor, the more likely that you're going to find AFib in these patients with so-called cryptogenic stroke. But as I said, these are ambulatory ECGs. So there are certain limitations when you analyze these ECGs, and if you're not aware or if your quality of tracing is not good, you would make a wrong diagnosis. So be careful of any pseudo-arrhythmias being diagnosed. For example, if you look at the bottom strip here, you get a feeling that there is some kind of atrial arrhythmia. But that's the value of having 2 or 3 leads, because the other channel clearly shows you that there is sinus rhythm. If you look at this bottom strip, you would think that this channel shows you a VT. But if you look at the same time that the lower channel is recorded, there is absolutely sinus rhythm, and then you can even trace this back every time that it's just there are spikes in between which represent the QRS, and this is purely a motion artifact. So Holters may be susceptible to this wrong diagnosis, and that's why I say that it is important in Holter that I get a chance to review so that you don't make wrong diagnosis. Now, diagnosing arrhythmias, as I said, somebody comes with syncope, obviously it is important. If he has, for example, LBBB, you want to diagnose a paroxysmal AV block. If he has sinus bradycardia, you are thinking of sinus node dysfunction. And the more you monitor, the more likely you are going to find these bradyarrhythmias and be able to decide on a cause of syncope. So the ECG might make you suspect, for example, somebody has a RBBB, LHB and a syncope. Unless you diagnose a high-grade AV block, it's difficult to suggest a pacemaker implantation. So therefore, in syncope particularly, that's probably the most common symptom for which one does a Holter. Here are examples of what you might find. So for example, here you see that there is a sinus node dysfunction. There are pauses with an junctional escape bit coming thereafter. If the pause is more than 3 seconds, as you all know that it's supposed to be significant. Whereas here, in a patient who has ischemic heart disease and LVEF of say 40% has had a syncope, you put a Holter and you find these non-sustained VTs repeating, you know that this patient is at a high risk of sudden cardiac death and makes an AICD indication. So therefore, a Holter in syncope can reveal some of these diagnoses which may lead to a definitive treatment in terms of a device implant or an appropriate device implant. Many times people come with symptoms of palpitations. They come very often to your clinic that if they feel thuds in the chest. You put a Holter and you see PVCs like this. You see these are isolated, long coupled PVCs, monomorphic, infrequently repeating. If you had a 12-lead Holter and you saw that they were outflow tract type of PVCs, meaning you have tall Rs in 2, 3 and AVF. So these isolated, late coupled, infrequent PVCs, they may be the cause of symptoms, but you know that there is no life-threatening event that is expected if these people have a structurally normal heart on the echo, and what you need is either reassure or at the most, depending on the symptoms, prescribe a beta blocker. Whereas sometimes they talk of short bursts of palpitations. This is usually a hypertensive guy who is 65-year-old. You know that paroxysmal AF is the most common arrhythmia. but unless you proactively diagnose, it becomes difficult to prescribe. And in this case, when you put a Holter, you saw that there was a short run of non-sustained atrial tachycardia. So palpitations, until you have an event ECG, would need a rhythm monitoring to make a definitive diagnosis. This is really something that, well, probably this is all too frequent, but the kind of patient that I told you, LV systolic dysfunction with LV ejection fraction of 35%, a history of syncope. Now syncope in a patient with LV systolic dysfunction is an ominous symptom. It suggests a ventricular tachycardia. But it is very difficult because there are n number of other causes of syncope. For example, these patients with LV systolic dysfunction are treated with drugs that cause hypotension, are treated with diuretics. So they are prone to orthostatic hypotension. Sometimes they are elderly with gait instability. Sometimes there is difficulty in taking a history of syncope because you have no bystander to tell you. And in these patients, if you see recurrent non-sustained VT in somebody who has LV systolic dysfunction, this becomes a very high risk situation with a risk of sudden cardiac death, and it becomes a no-brainer to suggest an AICD to this patient. It's the same if the cause of LV systolic dysfunction is dilated cardiomyopathy. Probably these are the two most well-studied causes for LV systolic dysfunction: post-infarct LV systolic dysfunction, dilated cardiomyopathy. In these patients, if you have a syncope, your level of threat in terms of dealing with a VT is already very high. A Holter or a 7-day loop monitor might help you to diagnose that, because the next thing that you do then is a EP study to see if you have inducibility of VT. If you can non-invasively diagnose this, you're already started in terms of a definitive management plan. There are other situations where a syncope in structural heart disease can be related to VT. I'll deal with it very shortly. Hypertrophic cardiomyopathy, you know, comes with a lot of problems. Diastolic dysfunction, dyspnea, mitral regurgitation, dyspnea. Syncope can be because of LV outflow obstruction, so they can have exertional syncope, but they also have a myocardial disarray, and therefore they are prone to ventricular arrhythmias. So syncope in a patient with hypertrophic cardiomyopathy, or in an athlete who is later diagnosed to have a hypertrophic cardiomyopathy, is a serious business. And therefore, once again, a great role of doing rhythm monitoring. But because they have hypertrophy, they have diastolic dysfunction, they have enlarged atria, they are also at risk of atrial fibrillation. And sometimes atrial fibrillation in these patients who have significant diastolic dysfunction, the moment you have atrial fibrillation, the blood pressure drops. And sometimes syncope can also be because of AFib. So you want to make a definitive diagnosis. And therefore, HCM, there is a lot of value to doing rhythm monitoring, particularly when a patient has symptoms of syncope. Arrhythmogenic right ventricular cardiomyopathy is another disease where predominantly the right ventricle is involved, and for the same kind of symptoms. If a patient with ARVC has syncope or palpitations, Holter would help you to diagnose. Plus sometimes these are congenital diseases, these are familial diseases, and therefore it might be worthwhile to screen the relatives or first degree relatives of these patients with HCM and ARVC by doing a Holter to see if they are predisposed to this. And then there are a whole set of these conditions. So WPW, now many times adolescent is referred to you with the ECG done for something else where WPW is detected. And the question asked to me as an electrophysiologist is, do you want to ablate the accessory pathway in this child showing WPW? Now ablation in WPW is purely for symptoms of palpitations. If somebody is asymptomatic, then you got to decide whether he is having a short accessory pathway refractory period. So you do a stress test and you see whether the accessory pathway or the WPW disappears. Similarly, you can do a Holter. In a patient who is referred to you with an asymptomatic WPW, if your Holter shows intermittent pre-excitation, meaning at some beats there is a pre-excitation, in other beats there is not, a narrow QRS, then these patients have a long refractory period of the accessory pathway. They are very less likely to get tachycardia and palpitations. They are even less likely to get atrial fibrillation with a rapid conduction down to the ventricle by that pathway, which is a risk in terms of sudden cardiac death. So therefore, if there is an intermittent pre-excitation in a patient with asymptomatic WPW, you know that this patient is at a lesser risk, and therefore you may consider ablation only when he has symptoms. And then there are a whole lot of electrical disorders like long QT syndrome, Brugada syndrome, catecholinergic polymorphic VT. These are electrical disorders where the heart is structurally normal. If these patients have syncope, you may do a Holter, because all these electrical disorders, the long QT, Brugada, you know long QT usually should come with a corrected QT which is longer than 500 or 520. You know Brugada should come with a right bundle branch block type of pattern with code of ST elevation in V1, V2. But these findings are not there all the time. They are temporally varying. So at one day your ECG may show the findings, the other day not. And that is the value of Holter in these patients. For example, in a young child with syncope or a young person resuscitated, if you find that the ECG shows a suspicion of a Brugada or a long QT, you want to really know whether it's happening all the time, whether the QT is stretching longer than what it is. Sometimes the ECG is normal and you are still suspecting this to be the cause. Then a Holter helps you to diagnose if there is a temporal variation in the ECG. At other times the ECG shows features which are typical for a long QT or Brugada. So that's where your Holter can be useful. Then I already talked to you about PVC monitoring. So if somebody has, say, somebody talks of palpitation and his office ECG shows an isolated ectopy, ventricular ectopy, then you want to know what is the total burden of ectopy. So for example, if somebody has a structurally normal heart and isolated ventricular ectopy, if they are happening about more than 20,000 per day, so more the burden of the ventricular ectopy, more the chance of getting into a tachycardiomyopathy. So therefore, even in people who have so-called benign ectopy, a Holter will have value to ascertain the burden of the ventricular ectopy. If the burden of the ventricular ectopy is more, then amongst 10% of them are prone to get a tachycardiomyopathy, and therefore they may be candidate for ablation even if they are isolated ectopy. Sometimes you are prescribing drugs for a non-sustained idiopathic VT, amiodarone or beta blockers, and you want to see whether the arrhythmia suppression is good. Not necessarily a great indication, but many times you're cost constrained. In India, you probably can't give ICD to everyone you would like to give for a class 1 or class 2A indication. Then it could be of value that you are prescribing amiodarone plus beta blocker, and a Holter might help to tell you whether that arrhythmia is suppressed enough or not. Many times post ablation of a ventricular ectopy, it could be useful to see if there are recurrences. Atrial fibrillation is probably where the value is definitely more. For example, many times atrial fibrillation is a part of a tachybrady syndrome. So in a patient with atrial fibrillation, he may have paroxysmal AF at one time, he may have sinus node dysfunction with long pauses at other time. So therefore the answer may be to first put a pacemaker and prescribe good antiarrhythmic drugs. The pacemaker will take care of bradycardia, the antiarrhythmic drugs may control the AF enough. So that's value. Another aspect is not everything is atrial fibrillation when you see a atrial tachyarrhythmia. You got to make a difference between whether you are seeing a atrial flutter or a atrial tachycardia. Once again, something that is not very well appreciated and may be revealed by the Holter. If you see a typical atrial flutter, then a typical atrial flutter is very well ablated. A atrial tachycardia is a focal ablation and therefore once again very well done. Atrial fibrillation is a much extensive ablation to isolate the pulmonary veins. So therefore I like to make a difference between whether the atrial tachyarrhythmia that he is getting could be atrial flutter or atrial tachycardia, or is it really AF? My threshold for ablating a AF is very high. It is also likely that in a 24-hour recording you may see that somebody has more atrial flutter and less atrial fibrillation. If that be the case, then I would ablate the atrial flutter, because atrial flutter usually leads to fast ventricular rates. So if I give him the benefit of ablating atrial flutter, atrial fibrillation may be easy to deal with. On the other hand, if his Holter shows more of atrial fibrillation and less of atrial flutter, then I might prescribe drugs. So it is useful even in a patient who has AF to do a Holter. Rarely in young patients, the tachycardia starts as a AV NRT which degenerates into a atrial fibrillation. AV NRT is a type of SVT, you know, which is very well ablated. So in a young patient with atrial fibrillation, you should do a Holter, because you might see a regular SVT or a atrial arrhythmia that can be ablated. So you may not assume that this is atrial fibrillation and keep a high threshold for ablation. So young patients with AFib, it's useful to do a Holter. Cryptogenic stroke, I think I already dealt with, that there is an increasing value of doing rhythm monitoring in the so-called patients who have no cause for stroke, because atrial fibrillation is 1 in 6 strokes is because of atrial fibrillation. And anticoagulation would only be prescribed, you know that the CHADS-VAS score goes to 2 the moment somebody has a stroke or a TIA. So therefore, if you diagnose atrial fibrillation in a cryptogenic stroke patient, your management is definitely changing, even if it's drug management. Another aspect in atrial fibrillation is sometimes atrial fibrillation is permanent. Now, if you keep a good rate control, the control of symptoms and the worsening of tachycardiomyopathy is going to be less. So if somebody has permanent AFib, I prescribe him digoxin plus beta blocker or beta blocker plus verapamil. My plan is to do a rate control. But am I doing a good rate control throughout the day, through all his activities of daily life? A Holter will tell me that. Because an hour to hour you get an analysis of the Holter, what is the minimum rate, what is the average rate, what is the peak heart rate. So if the peak heart rates in the rest are less than 80 and if the maximum heart rate all through the hours wake time is less than 100, then I believe that I am doing a good rate control. I will not step up the drugs. So even when you decide to do a rate control in a permanent atrial fibrillation patient, a Holter tells you whether you are meeting your target adequately, then you hope that the chance of worsening of LV function because of atrial fibrillation is less. One more interesting indication I will tell you is in a post-CRT patient. So person who has received a biventricular pacemaker or a CRT pacemaker, if they have atrial fibrillation, many times you know that heart failure and atrial fibrillation are married to one another. Heart failure leads to AF, AF worsens heart failure. So when a patient with heart failure, LBBB, your standard indication gets a CRT device or a biventricular pacemaker device, he was in sinus rhythm. But now when he develops AFib, your ventricular rates go very fast. And that time your pacemaker is not working as a biventricular pacemaker, he is having intrinsic conduction at those faster rates. You don't want that. Otherwise your biventricular pacemaker is not working. So therefore these patients would need an ablation of the AV node if he has atrial fibrillation happening recurrently, so that his biventricular pacemaker works like a biventricular pacemaker. So these are some of them are niche indications, some of them are broad indications which are of utility to you in your daily practice. But Holter is very useful for not only diagnosing the arrhythmia, but also managing the arrhythmia and also prognosticating the arrhythmia. Even after a device implant, it makes sense to have a Holter. For example, many times pacemaker malfunction is not very common, but you have the leads which are prone to damage. So if the leads have a sensing problem or there is a microfracture in the lead, the conductor of the lead, then there could be loss of pacing. And despite the pacemaker, 7 years down the line, somebody is talking of syncope. Now all these arrhythmia devices, pacemakers, ICDs, CRTs have a very good arrhythmia log, but they are not the same as Holter. So if you do a Holter and if you see that there is a noise which causes sensing, causes inhibition of the pacemaker, or there is a pacing spike but there is not a capture, so you can pick up pacemaker malfunction when you do Holter in a patient who has syncope. Similarly, I told you about CRT already, that atrial fibrillation in a CRT patient needs to be managed differently, and therefore even after a device implant, a Holter can sometimes be useful. So there is a great use of doing rhythm monitoring at all points in the patients who have symptoms of, say, palpitation, syncope, but also patients who have LV systolic dysfunction to diagnose VT, and also patients who have already got a device to manage their rhythm disorders. I think I'll stop here, and if there are a few questions and time available, we can deal. Yeah, so there are a lot of these devices. I drilled very broadly, but you're right, there are a lot of these devices that are available, Apple Watch, and there are a lot of watches and things that are available. Sometimes they give only the analog reading of the heart rate, sometimes they have a single lead ECG that is available. So actually anything that gives you an idea is useful, particularly in patients who have short episodes of palpitations, because you are not able to diagnose them many a times with a 24-hour or even a 7-day Holter, and you don't put an implantable loop recorder every day because it's finally an implant, and therefore an Apple Watch like that, if somebody has symptoms say once in a month, would be a great idea to know that he gets the symptoms because of paroxysmal AF. So a lot of rhythm, more the rhythm monitoring that is possible, more the merrier, because we are likely to make a rhythm diagnosis. One only has to be careful that one doesn't detect artifacts as arrhythmias. That's the only care I think we need to take. So we should know the fidelity of every device when you consider as a rhythm monitoring device. That is not defined. A number of things there are uncertain as to how long you should monitor. All these questions cannot be answered very well categorically. But in a situation like hypertension, LV systolic dysfunction, diabetes. So when your CHA2DS2-VAS score is high and then an AF is more likely, then probably you should monitor at least for 48 hours. But then there is not only a discussion of how long you should monitor, but there would also be a discussion of how long a AF should be considered as significant and related to stroke. So whether it is 30 seconds or whether it is 6 minutes. So there are a lot of unsettled issues there. Correct. So we don't have definite answers as to how exactly to go about it. More artifacts in patients who are less than 60 years. Correct. So I guess there nothing is sticking onto the surface, and therefore probably the artifact possibility would be a little more. And atrial fibrillation, I guess the ventricular signals can be picked up easily, but the atrial signals in any of these monitoring devices is a concern, and therefore you are probably relying on a variation of RR to diagnose AFib, then really picking up a good atrial signal all the time. So yeah, artifacts probably would tend to be a little more there.
Thank you very much, Dr. Ashish Nabar, sir.
Yeah.
Now may
Thank
I please request chairperson to felicitate Dr. Ashish Nabar with a small memento. Let's move to the next session. We will hear about interesting cases of cardiac surgery from our own cardiac surgeon, Dr. Vipul Waghela, sir. May I please request chairpersons Dr. Arvind Iyer, sir, Dr. Amber Limie, and Dr. Krute Shah to come on the dais.
Good afternoon, friends. Vipul Waghela is known to everybody. I request Vipul Waghela to begin his talk in the interest of time.
Good afternoon, everybody. I'm going to give only 10 minutes presentation. In this presentation, 1 or 2 slides followed by one small 2 minutes video, which is a video case presentation, and little bit discussion on that particular case. And basically, after the video, whatever talk is there, that is related to what are the difficulties as a surgeon and as a team we face in our day-to-day practice, especially in emergency cases. With a very short notice, Dr. Banker told me to give this lecture, and I didn't have any clue what to speak. And Dr. Javli was already speaking on transplant and heart failure, and everybody has in the last 15 years, almost all routine talks and topics are covered. So I was left with no option. So recently, me and my wife watched that movie called URI, A Surgical Strike. Next day morning, again I went and saw that movie again, and then inspired me to give a talk on surgical strike. So first I'll define what is surgical strike. So surgical strike is basically a military attack which is intended to damage only legitimate military target with no or minimal collateral damage to surrounding structure or vehicle or building or general public infrastructure or utilities. Similarly, it's quite similar, but our is not called as a surgical strike. It is an emergency surgical measures and are intended to rescue patient life by legitimate surgery with no or minimal collateral damage to target organ or supportive other system infrastructure with minimal financial burden. I used infrastructure because nowadays the bystander doesn't accept mortality and they start breaking our infrastructure. So it is very important in current scenario. This is a video. It's a video presentation. While video is running, I'm going to speak regarding the case. She was a 56-year-old female, triple vessel disease diagnosed, diabetic, hypertensive, came as an elective coronary angiography, then advised PTCA or bypass operation. So naturally, most of the patient opt for PTCA. So she also underwent PTCA. And normally this doesn't happen, but it happened with this patient, unfortunately. That guide wire passed through the LED and it was stented, but balloon was not coming out. It was very difficult to remove that balloon catheter and with the wire. So while process of removing the wire, the balloon got broken inside. So we left with no option. The cardiologist called immediately. So we wheeled in that patient in the theater. We have put the patient on heart-lung machine. And we grafted LED and one of the diagonal, the OMs were normal. Right coronary had a disease, so PDA also grafted. We opened the LED proximally on beating heart, pump supported. And while opening the LED, you can see there's the tip of the catheter, balloon, and as well as the stent. And it was so much stuck because of the calcific lesion there, because the lesion was long and calcific, heavily calcific. So we removed that whole thing. To remove that, I had to extend the arteriotomy further up and remove even the atheroma. So practically, I had to do stent endarterectomy. And that whatever arteriotomy was there, which was later on closed with the Prolene 7O. You can see a lot of tough tissue there. I had to remove piecemeally, slowly, all the small atheroma. And you can see distally two grafts, LED and a diagonal there. You can see the wire came out and almost it was around 15 centimeter wire, balloon and wire. Because the patient was having a hemodynamic instability, patient was on IABP, and we have to immediately build in this patient. This patient was loaded with ecospin, clopidogrel, GPTB3 inhibitors, whatever Dr. Praful has said recently, you can give this, that, everything, all masala was there, and then this patient also, obviously, such patient bleeds a lot in the post-operative setting, and she also bled, and we had to transfuse a lot of blood. So after removal of this, we have sutured that area and came up with good hemodynamic with IBP. So point is not that. The point is that what are the different type of cardiac emergency we faces in day-to-day life. In this last 13, 14 years of Bankers Group of Hospital Association, we have operated around 6,000 plus routine surgeries, adult surgeries, as well as pediatric. In that, we have faced these type of cases, and these are enumerated. However, in last 2 decades, the cardiac surgical emergencies has came down drastically. Nowadays, in last 3-4 years, we hardly get a call for emergency cases. Okay, but these are our experiences. The coronary artery disease related issue, failed PTCA, dissection, perforation, hardware malfunction. Valvular heart disease usually present in an emergency situation like endocarditis, acute valve regurgitation because of the rupture chorda tendoni, or stuck valve prosthesis. The mechanical valve gets stuck because of either a clot or a pannus. Then the acute dissecting aneurysm of aorta, we get almost every 2 months, 1 or 2 patients. Embolization of clot from the LV cavity or LA cavity, and device embolization like PT after the embolization of PDA, embolization of ASD device, BSD device. These are the cases we deal nowadays in our setup. Hardware malfunction, however, it is very rare, but this myojna and repeatedly using the same catheter again and again, and autoclaving and gassing, these devices lead to fragmentation, and sometimes malfunction can occur. And again, perforation with this hardware, like putting a temporary pacing cable from the femoral root, and especially in a situation like inferior wall MI, where the myocardium is already very friable, in that even the little push into RV cavity, it can lead to free wall perforation. So certain perforation, you need to go immediately in and tackle that whatever problems patient is having, and then after that we need to decide what is the definitive thing we need to do for that particular patient. Another thing in valve, I forget to tell, that many patients go for a balloon mitral valvotomy. Nowadays we don't get much patient in an emergency situation, but during the balloon mitral valvotomy, patient can develop acute MR, patient can have free wall rupture. So these type of patient comes for emergency cases. Then the post-MI complication like free wall rupture, very rare, hardly they reach hospital in a live situation, but if they, we have to take them inside as early as possible. Similarly, acute MR, you need to address as early as possible. Septal rupture and cardiac tamponade, especially after post cardiac surgery or any cath lab intervention related cardiac tamponade. Now these all indications, all type of emergency, if you don't operate, there's a 100% mortality. Patient can survive only and only with the surgery. However, there is a risk of, there is a mortality rate in hospital, and operation table mortality rate, it goes from 9% to 23% depending on availability of mechanical circulatory devices, strong intensivist facility, and dedicated team. Now, if you quick look at the angioplasties, there is a number of intervention which is increased from 2013 to 2014, around 14% increase. And from 14 to 2018, especially after this government scheme, it has gone 54%. Not only that, the primary angioplasty, the number has gone 68%. And mortality rate in primary angioplasty, which was 0.89, it has gone to 1.25, around 40% increase from the 2013. If you see in USA, every 1,000 patient, 32 patient undergoes angioplasty, whereas in India, only 3. And still, in our India, the number of angioplasties are too many, and it is expanding. Now, reason for expansion is many, because the facilities are available. Previously on the big center only doing angioplasties. Now even the small peripheral centers like Dahod, Bharuch, Valsad, Vapi, everywhere the cath labs are there. And now not only one cath lab, there are 2, 3, 4. Not only that, there are budding new interventional cardiologists and very aggressive one. There is an increased number of procedures because of that. There is a widening of indication for PTCA. Previously, the bifurcation stenting was not there. Now bifurcation stenting is there. Chronic total occluded vessels, they never used to do. Now it is also possible with that. So because of the hardware, now lot of development in the hardware and the facilities are available. So complex PTCA is there in the pipeline now. Now the good thing about the angioplasty is the most center across the India, there is a documented extremely low incidence of emergency surgical procedure because of the good quality available stenting. Like previously there is only bare metal stent. Now good quality DES is available. Not only that, the cover stent also available. Then the guiding wire, there are also a lot of development in that. So perforation rate is also gone down drastically. Now emergency surgery after failed PTCA, reported incidence is 0.6% to around 21%. Again, it depends and different way. And I'm going to talk about that in the next slide. Now, in your city, if there is a teaching hospital which perform complex PTCA, should have on-site surgical backup and a mechanical circulatory system like IABP, ECMO, LVAD, all these facilities should be there. There are centers where there is no surgical backup. The surgeons are not on full time. There is no operation theater available. Even they don't have heart-lung machine. And none of this facility. IABP, every hospital is there, but ECMO and LVADs are not available. We are lucky to have 2 dedicated cardiac surgical team. We have 3 heart-lung machine, 3 or 4 IABP, ECMO, and LVAD facilities. Not only that, we have a perfusion system. We have a perfusion, it's the 2 teams, and the 2 cardiac anesthetists. So I'm coming to the point why it is so important to have 2 teams. Why it is important to have 2 operating room in one single hospital. So these are small things, but it does matter when you are operating or doing a complex PTCA in a center of excellence. Emergency surgery may be vary between institution and may vary with the same institution over a time. Especially there is a difference in PTCA operator experience, aggressiveness of that cardiologist, angioplasty population, like very bad disease population, availability of bailout technique, like suppose there is some malfunction. I said bailout technique, like suppose perforation. If you have available cover stand, that patient will not come to a surgical site and that patient will survive. Similarly, if there is a broken or rupture tip of any hardware, there are retrievable hardwares are available, and good thing is there. In last 13 years, I got only 2 times call to remove that hardware. Most of the time, the team removes by themselves because of they have availability of good hardware to retrieve. Surgical backup and referral is also important. They have to, cardiologist has to quickly diagnose, immediately they have to call us to intervene as early as possible so that we can, because the time is a money in that. Not only that, each cath lab or each unit should have their own interventional criteria. And we are very lucky we have our hospital. There is a strong intervention criteria. And because of that, we are also flooded with a lot of cases. Thanks to Dr. Banker for making such criteria. Now, whenever there is an emergency, the two situations can be there. One is, this is group 1, that is a crash bypass. Another one is a patient is a little stable, but require a urgent bypass. And both the situation, if you don't do anything, patient is going to die. So group 1 includes the patient in asystole, intractable VF, or profound shock, unresponsive to any inotropic support, and which require immediate cardiopulmonary bypass and surgical revascularization or any surgery. These patients require cardiac massage until bypass is established. CPB in OR or cath lab or in recovery ICU, we can institute, and any OT staff can do that. Now group 2 patient, that is a patient which is stable but maintain systemic pressure with or without inotropic drugs and having adequate organ perfusion. The urgent revascularization or any urgent surgery can be performed in OR as soon as facilities and staff is available. The complication after emergency surgeries are like myocardial infarction, arrhythmias, low cardiac output state, wound infection, renal abnormality, cerebral issues, septicemia, and these are standard. Then operative mortality and in-hospital mortality. Now, whenever surgical unit does emergency work, their statistic will not be good, because these all things are very high in all emergency case. So surgeon who doesn't take this emergency case, the statistic will be fantastic. 0% mortality, 1% mortality, less than 1%. The surgeon who takes such cases, they will be having 4 or 3% mortality, morbidity will be little higher. Okay, so you have to judge according to which unit is doing what. So that is the thing. So what are the challenges when the unit does high risk cardiac emergencies? First commonest problem in any cardiology unit or cardiac surgical unit, 2 minutes. Non-availability of on-site surgical backup. Second thing is, even if there is a available surgical backup, the most units are busy, so there is no slot available. So for that only you require a 2 team and 2 operating room in each place, each heart center. And the Dr. Banker had a vision that we should have average in each hospital at least minimum 2 theater and 2 team. And thank you so much for that, because of that we are able to do multiple cases at the same time. Another thing is unstable hemodynamic. Most of these patients are having unstable hemodynamic, unstable rhythm. Timing of surgery is very important, and most of the patients are anticoagulated and on antiplatelet. A lot of blood products are required, and not only products, but product related issues also we have to tackle. Planning and execution of surgery. Each surgery we need to plan out with the whole team. The team decide plan A, plan B, plan C. If one fails, what next? The second fails, what next? And we have to have experience, skill, and very motivated surgical staff, because in emergency you require a very motivated and experienced staff only. And whereas in elective, any staff can be okay. The communication with the relative, this is the most important, and we have to communicate to the relative regarding the nature of the disease, the current situation, whatever happened, the plan of action and a risk involved, and we need to document this in the case paper. That is also important. The course and the monitoring is documented in the paper to avoid any later on issues. Backup of mechanical circulatory support, because if you want to reduce the mortality rate in such patients, you need to have a mechanical circulatory support system. And not only one IABP, you have to have 2 or 3 backup, because it's a high volume center. Most of the centers are high volume nowadays. Another thing is you need to talk to account department and the patient relative regarding the finances, because once the patient is having any cardiac complication, the bill amounts sky high, and it goes very rapidly high, and you need to inform them in a very concerned way as early as possible. Not only that, there are a lot of psychological issues are also involved, so you need to take consideration of counselors also. So predictor of, just last slide, the predictor of bad outcomes are timing of surgery. The delay in the surgery going to have a very bad outcome. Extent of coronary artery disease, multivessel disease, hemodynamic preoperatively very stiff support, rhythm abnormality like patient is fibrillating, patient is on massage, and female sex, very advanced age, preoperative renal parameter greater than 2 creatinine, severity of functional impairment like ejection fraction less than 30 or 35%, multiple blood product use, crash bypass, and cardiac massage. These are the predictor of bad outcome. Thank you so much.
Thank you, Dr. Vipul Waghela, for a lucid and informative talk. I request chairpersons to present memento to our speaker, Dr. Vipul Waghela. Thank you, sir. Thank you, chairperson. Our next topic is arrhythmia quiz by Dr. Ronak Ruparelia. And to chair the session, I would like to invite Dr. Jagdish Chaudhary, Dr. Kishan Jani, and Dr. Vishwa Unadkat. Dr. Ronak has done DNB cardiology from Nanavati Hospital, Mumbai, and recently joined Bankers Group of Hospitals as consultant and interventional cardiologist. Please keep your voting pads ready because it's an arrhythmia quiz, so we all need to participate. And please hold it right so the options are in the sequence of 1, 2, 3, 4.
Good afternoon, everyone. So when we talk about arrhythmia, first of all, many arrhythmias look alike. But if you look at it closely, there are many clues are hidden in the ECG itself to diagnose the arrhythmia. Without wasting much time, we'll go to the quiz. There was a 31-year-old male who presented to us with complaint of palpitation. He had on and off history of chest discomfort. There was no syncope or near syncope. Patient's echocardiogram was normal. Similar complaint, also patient had similar complaint 1 month ago, which was related by some medication, which we don't know as of now what was the medication. This was his ECG on presentation. And these are your options. Can we have the timer on? So almost many people say it was SVT with aberrancy. There is some tie between sinus tachycardia and VT. So if you look at the ECG closely, can we have ECG on both the screens? If you look at the ECG, there is some RBBB type of pattern. If you will look at V1 closely, the first beat is RBBB, second is RBB, third beat is something different. Fourth, again there is RBBB. And if you look at third beat, it is definitely different in all the leads. Plus, if you will look at closely, there is northwest axis, which does not occur with sinus tachycardia. So sinus tachycardia is out. So option remains SVT with aberrancy versus VT. This beat, it determines that there is some fusion complexes going on. there is some fusion between sinus beat as well as some ventricular ectopic beat. So this was basically a case of ventricular tachycardia. To be particular, this was right bundle branch block pattern with northwest axis or superior axis, which goes in favor of fascicular VT arising from the left posterior fascicle. So what you will do for this patient, how you will treat this patient? The options are amiodarone, adenosine, verapamil and digoxin. Can we have the timer? So again, many people say amiodarone. Amiodarone, yes, it's a good drug, but every time amiodarone doesn't work, and it's very harmful drug over a long period of time. Adenosine usually does not work in ventricular arrhythmias. So correct option for this is verapamil. This kind of arrhythmias for fascicular VT, the calcium channel blockers are the drug of choice, particularly verapamil. If verapamil is not available, diltiazem can be tried, and it has a good success rate. So this patient was followed up on next day post verapamil. This was after 15 milligram of verapamil, and this was the patient's ECG on next day. Patient presented to us in night, so this was around after 12 hours of the verapamil. So would you advise this patient coronary angiography? Can we have the timer? Almost time. These are memory T waves. Usually if you look at the arrhythmia ECG, wherever there is a negative QRS complex, lead 2, 3, AVF, V4, V5, V6, V3, there we are seeing T inversions in V3, V4, V5, V6, 2, 3, AVF. So this is a phenomena called memory T waves. The T wave will retain memory of the previous QRS complexes which were there during the arrhythmias. So this T wave does not signify any ischemia or any infarct. These T waves are just retaining the memory of previous QRS during arrhythmia. Usually such kind of patient require follow-up. This patient was followed up for a week. He was discharged, he was called back after a week, and this was his ECG after a week. All T wave has been normalized and there was no at all sign of arrhythmia. Even during arrhythmia, his echo was absolutely normal. Then there is a next case, which was a 67-year-old male who presented to us with septicemia. He had renal dysfunction, on diuretic infusions, on amiodarone infusion for query atrial fibrillation, on ventilatory support for long time, and he developed tachycardia in the ICU. These are the ICU monitor screenshots. And so what does this arrhythmia is? Polymorphic VT, is it artifacts, is it SVT with aberrancy, or it is atrial fibrillation? Can we have the timer? Okay, so majority has picked up it correctly. These are polymorphic QT. If you look at the QT interval, just prior to the development of this rhythm, the QT interval was grossly prolonged. QT interval could have been prolonged because of amiodarone, can be because patient was in septicemia, he can have electrolyte abnormalities. This was the rhythm just before the onset of the arrhythmias in the morning time, and this was his morning ECG, which was not seen by anyone, and patient developed arrhythmia, and his potassium was 3. So this was a polymorphic VT arising due to long QT interval. Now coming to the next case, there was a 26-year-old female, no previous cardiac illness, known case of bronchial asthma, presented with palpitation. She had history of excessive inhalation of formoterol to get relieved of the breathlessness. This was her ECG on presentation. Can we have the timer? So 32% says atrial tachycardia, 48% says sinus tachycardia. Now here the rate is more than 150. Why sinus tachycardia at the rate of more than 150? And if you look at the QRS closely in lead V1, can you find anything abnormal in lead V1? Yes, there is after QRS there is a small P wave which is a pseudo P wave. If I'll enlarge that, there is a pseudo P wave. In the upper small ECG, there is a pseudo P wave, and then lower ECG is after Valsalva maneuver, which is a sinus ECG. And even in long lead 2, if you will see long lead 2, there is a pseudo S wave also. Particularly here, there is a pseudo S wave just after the QRS complexes. So this kind of abnormality, RS-R' pattern during tachycardia, after sinus rhythm ECG, there is no RS-R' pattern. This suggests that there is some P waves are hidden in the QRS complex, which is coming immediately after the QRS because of AV nodal reentrant tachycardia. So this was a case of AV nodal reentrant tachycardia. Now, one more interesting case, there was a 58-year male admitted with history of breathlessness, past history of fast heartbeat, required electrical cardioversion 1 year ago. Patient was on tablet amiodarone, which was stopped recently by himself, and he again presented to us with palpitation. This was his ECG on presentation. If I'll tell you about his echo, does not have a normal heart. His echo did show LV dysfunction with LV function of around 45% ejection fraction. So these are your options: SVT with aberrancy VT, sinus tachycardia, and atrial flutter. Can we have the timer? So SVT with aberrancy and VT. Again, this kind of ECG very narrow QRS complex. It does not fit into any criteria of VT. Even axis is normal axis. Does not fit into criteria of VT. So only thing we are left with SVT with aberrancy, atrial flutter. Sinus tachycardia cannot have so fast heart rate. We thought it is SVT with aberrancy. Decided to give patient amiodarone. Before we can give amiodarone, somebody took another ECG which was like this. Now you want to reconsider your diagnosis, or you are same with your previous diagnosis? Can we have the timers? नहीं है, ठीक है. How many says SVT with aberrancy? Nobody. How many says atrial flutter? Quite. How many says VT? 3, 4, 5, 6, 10. So this was not VT, definitely. We committed in last slide this is not VT because of the narrow QRS complex. What happened here was, if we will enlarge these two areas, if you look carefully, there are two hidden P waves are there. The patient himself showed that there are two P waves, negative P waves in lead 2. Even at the end, there are two negative P waves are there. So initially what happened, it was 1:1 flutter. Because of that, rate was nearly 300, and at this place the rate got 150. Anyway, patient was given amiodarone, and after amiodarone, this was patient's ECG. All P waves are clearly apparent. In lead 3 there are negative P waves, 2 P waves between 2 QRS. So that was atrial flutter actually, which got picked up by chance. Next case is a 46-year-old female who presented to us with history of palpitation, no chest pain, no syncope. And this was her ECG. ये क्वेश्चन है. Yeah, so there is a almost tie between SVT with aberrancy versus flutter. But again, this is a LBBP type of QRS. In LBBP type of QRS, if you will see SVT versus VT criteria, with monophysics R wave in V6, it is SVT. Q wave, any Q wave in V6, usually LBBP does not have any Q wave in V6. If there is any Q wave in V6 is VT. Here, why this is not flutter? A good point is that yes, it can be flutter, but again we can see that the QRS is distorted at the end in lead 1 particularly, in lead V5. So this distorted QRS means that there is some P wave is hidden over there in lead V5, lead V1. So this suggests that this is not flutter. There is some retrograde conduction through the AV node, and that suggests that there is some AV NRT is going on. And particularly there is no Q wave in V6, it rules out VT. Now in interest of time, I'll skip some questions. Case 9, last one. Beach mein. There was a 44-year male under ICU care since 15 days, admitted with sepsis, who was improving now. One fine night we got a call from ICU that they are seeing some bizarre rhythm on the monitor, and this was the rhythm. So what you will do for this rhythm? Amiodarone, adenosine, immediate cardioversion, or Masterlin activity. The lower graph is not a ECG, lower graph is a respiratory graph or pulse oximeter. Pulse oximeter. Can we have time?
We can just have manual polling, just finding out the slide.
Okay, how many feels amiodarone? How many feels adenosine? How many feels immediate cardioversion? But I never said patient is unstable. How many feels Masterlin activity? Majority. Yes, this lower graph is a pulse oximeter graph, which is absolutely normal. And if you look at this graph, upper graph, closely, there are QRSs hidden there. One QRS is here, second is here. And if you will measure distance between these two QRS, and then we will plot it for the next QRS, definitely there are spikes over there. This spike is there, this spike is there, this spike is there. None of the arrhythmia shows such sharp spikes in between. All QRSs are visible over here. And this was his graph just before developing this rhythm, which definitely confirms that there are multiple artifacts are there in between. Now coming to last question. There was a 52-year-old male who presented to us with chest pain of 2 hours duration. This was his ECG. I am not going to ask any question on this. His angiography was done, primary PCI to LAD was done. This rhythm patient developed 6 hours after angioplasty to LAD. What is this? Anyone? This is complete heart block. So patient was given atropine. Post atropine, this was the rhythm. So what you will do for this patient who developed CHB 6 hours after angioplasty to LAD? Check potassium, reshoot angiogram for acute occlusion of RCA, degenerative conduction system disorder, nothing doing for that, and review angiogram just. Okay, I'll tell you potassium is normal. Reshoot angiogram, why reshoot angiogram? RCA inferior territories are not showing any elevations. Elevations are always there in V1, V2, V3, which was there previously also. It can't be degenerative conduction system disorder. Patient's age is against degenerative conduction system disorder. The correct option is review angiogram. Many times what happens after angioplasty of proximal LAD, if you will stent proximal LAD, if the first septal artery got occluded after stenting of LAD, patient will develop septal infarct. This kind of patient, in previous lecture we have seen that patient can develop arrhythmia, septal arrhythmias or septal VTs. The other possibility is that septal gets scarred and patient can develop CHP type of picture. Usually this type of picture requires temporary pacemaker, and after nearly 72 hours to a week, usually this kind of CHP resolves itself. If not, patient may require pacemaker. But usually in a week's time it settles. So that was the end of the lecture. Thank you all.
Thank you, Dr. Ronak, for this interesting quiz, and thank you, audience, for active participation. I'd like chairpersons to present memento to Dr. Ronak. Memento. And for next session, I would like to invite Dr. Pavan Roy and Dr. Suvankar Ghosh, cardiologists at Banker Group of Hospitals, to present some interesting cases. And this will be the last lecture. To chair the session, I would like to call Dr. Prakash Shah, Dr. Milind Patel, and Dr. Ashish Balsod.
HDM. The topic name seems to be interesting, and I hope the case is also interesting as well. Hope you are all not sleeping or maybe active, because there is active participation needed in this case. Now, this is a ECG. A patient came with chest pain since 8 hours with this ECG. I will give the details of the clinical history later on. Now, but just seeing this ECG, this patient comes to you in a private clinic. What will you make a diagnosis? I have given you 5 options. Either is, first of all, I will also ECG. As you can all see, there is a classical ST segment elevation in inferior leads with somewhat reciprocal ST depression seen in AVL. Otherwise, V1 to V6 are mostly normal. Considering the patient present with chest pain, what would you make a diagnosis? First is a routine acute ST elevation MI. Second may be ST elevation different causes like Prince metal angina, maybe acute pericarditis, Takotsubo cardiomyopathy, or early repolation syndrome. Can we start the timer, please? This is the ECG. Okay, so remember 69% of the house has voted for acute inferior MI. I will repeat this question again and again for 4 times again later on. Same answer, same questions, but the answer will be changing after each slide. Now coming to the history. This patient was an 18-year-old girl, school going, presented with chest pain with this ECG since 8 hours. There was no any past medical history significant, vitals were normal, routine blood investigations were normal, apart from some hemoglobin of 10.6. Now, what's your diagnosis again? After knowing that this patient is an 18-year-old girl, can we start the timer? The options will remain the same. Now, let's see what you make the diagnosis after knowing that this patient is 18-year-old girl. Start the timer. Remember, the first 69% considered as an MI. Okay, now only 3% believe that it is actually an MI. Okay. So majority think that it's either Prince metal angina, B, or fourth, that is Takotsubo cardiomyopathy. You may be right initially, you may be wrong. Let's see how the story goes on. So this is the diagnosis. Now patient, you know that this is an 18-year-old female girl with ST elevation in inferior leads. What will the next step will you be doing in your private clinic? Do a echo study to look for RWMA, do a cardiac enzyme routinely, whether there is a myocardial damage, really it is a MI or something else. Or send immediately for coronary angiography, considering it is MI. Patient is having chest pain. Though she is 18 years of girl, very rare to have a MI in such age, but let's send her for angiography. Or do repeat serial ECGs, like observe her in ICU and further. So again, the timer starts now. Let's see what you decide. Okay, so majority will do either echo or send her to angiography. Okay. Now we did a TROPI. TROPI came to be positive. Then we did a echo. Echo showed normal LV function, no RWMA, and no any other valvular abnormalities. There is some interesting finding in this echo, which I will tell you later on. If anyone can know, you can tell me now. Not for bankers, doctors. Everyone knows this case. Any idea? No. No valvular abnormalities. This is the other 4-chamber valve and a short axis. Okay, let's assume that this echo is normal. Echo is the normal report, no abnormalities. Now we did a serial ECG after 3 hours. What do you find in this ECG? Can anyone stand up and describe the ECG? Anyone in the front line? What happened to the ST elevations in inferior leads? They have gone down drastically, but still there is some elevation. And there is a T inversion present in AVL. Otherwise, the rest are same. The elevation has definitely gone down. The pain is also somewhat relieved. Now, what do you make provisional diagnosis based on all the findings we have done? TROPI came positive, echo shows normal. Serial ECG after 3 hours, there is a partial resolution of the elevation in inferior leads, and she is an 18-year-old girl. So, same five diagnoses. Let's start the timer. Okay, so how is it divided? Someone thinks it's a pericarditis, 23%. The majority, 36%, think that it's a Prince-Mental angina, coronary spasm, which is theoretically true. Yes, this young female coronary spasm is a very likely common factor which can give ST elevation and later on subside by itself. Fourth possibility is vasculitis. Definitely, Takayasuk arthritis can involve osteal RC and cause an MI. And Takotsubo cardiomyopathy, usually in middle-aged female, but still young-age females can also have some in rare presentation. But 5%, now the house is known that this is not an MI. Only 5% now believe that still it is an MI. Okay, so now what should be the next step in this, managing this case? Now we have done that echo is normal, only TROPI is positive, ST is resolved. What should be done next? Considering the patient first ECG was having significant ST elevation, would you still do serial ECGs, observe, and then conservative management and do nothing else? Or you will do an angiography to rule out any critical coronary artery disease? Or do a CT aortogram, as she is a female, high likelihood of having vasculitis, or do a CT thorax, considering that there may be a atypical presentation of a pericarditis, ST elevation which has resolved, and start around NSAIDs, discharge the patient next day. Or fifth possibility, just do a stress test, stress echo or TMT next day, and there is no objective evidence of ischemia. Just give her diltiazem and nicorandil for coronary vasospasm, considering as prinzmetal angina, and then discharge the patient. So these are the 5 possible management options which you have. Let's start the timer. What you will do? Okay, so the majority thinks that she should undergo a stress test and objective evidence of ischemia rule out. There is no need for any other further investigations. And the second most common answer is the third, which is CT aortogram for vasculitis. Theoretically, all you are correct. But we did eventually did an angiogram of this patient. Angiography came absolutely normal. As you can see, the RCN left system are absolutely normal with TIMI3 flow, no any residual even plaque or slow flow, nothing like that, absolutely normal. Now, same options again. After knowing that she is 18-year-old girl, TROPA is positive, echo normal, angiography normal. Now what will you do? Again the 5 options. What is the final diagnosis after doing all the investigations? Timer starts now. Okay, the house is dividing further. So majority think 37% think still it's prinzmetal angina. The other ones think that it's an acute pericarditis, 22%, and Takotsubo is also likely. But now MI has gone, inferior MI. Angio has also come normal. No one thinks that is an MI. Okay. Now kahani mein twist. We kept her under observation in the ICU. Next day ECG came like this. Can you see any changes in the ECG compared to previous ECG? 2-3 AV ST elevation has gone. Instead, there is a new onset ST elevation in 1 AVL and V4 to V6. And whereas there's ST depression in inferior leads actually, somewhat. So there is a new development of ST elevation in ECG. Previously there was inferior leads, now lateral leads, new onset ST elevation. Now what will the further step will you take? Considering the patient has still ongoing somewhat chest pain, we have done all the investigations. Echo is normal, angio is normal, everything. Only TROPA came to be positive. What will be the possible etiology? Can anyone guess? Why there is a new onset ST elevation in different area? So okay, I will given 4 options for that. What will you do next after going this ECG? Remind you that this ECG was taken on the next day. Option A, will you do a repeat echo to look for any new onset RWMA? Start NSAIDs, considering this acute pericarditis, there may be a different segmental involvement of pericardium and which can cause elevations in different area. Will you do a repeat TROPI, CPKMB, there is a reinfarction or like that? Or just keep her under observation and conservative management? Or you will do the most invasive approach, repeat angiography again next day. So can you start the timer please? There is some specific change in the ECG which I haven't told. Can you depict it? Which clinches the diagnosis. Okay, the house is fully divided now. Can anyone depict can you show the ECG please in the slide? Apart from the ST segment changes, can you depict any specific change in the ECG? No. The final ECG which I will show, that clinches the diagnosis. All these ECG have some minor specific change which clinches the diagnosis. There is somewhat change seen in this ECG, but it is hard to depict. Anyone? No. Yes, yes. PR segment? AVR, yes. But there is no significant elevation. Mild. Okay. So now the house is divided. Some said a repeat echo, some said start and sets. Now this is the final ECG, which we took next day again after 2 to 3 hours. Now can you see the changes? There is a classical PR depression in 2-3 AVF as well as PR segment elevation in AVR, which depicts the diagnosis as pericarditis. There is also a VPCs present in the V4, V6. Basically, CT thorax was also done in this patient, which came normal to rule out any pericarditis. Patient responded well to NSAIDs and was discharged on the 3rd day. Patient came for follow-up again after 2 months, and she was absolutely asymptomatic. Echo was absolutely normal. So lessons to be learned from this case. Not all ST elevations are MIs, which you in the first time I asked the options, 90%, 16 and 70% said it is an MI. But after every time, 3 to 5% only said MI. Second is the pericarditis, vasculitis, myocarditis, coronary vasospasm should be taken into consideration in young individuals, especially in females present with ST elevation ACS. And atypical presentation of common diseases, which we found in this case, pericarditis, but the PR segment depression was not classical until the last ECG, which came in the 2nd day. Pericarditis can cause false elevation, it is written. So basically the final diagnosis would be acute pericarditis, mostly viral, which very well responded to NSAIDs. Patient became asymptomatic on the 2nd day. Though the ECG changes on the first ECG, this was the first ECG which I will come
Why
on.
the echo was normal?
The echo showed somewhat glistening or hyper echogenicity, especially in the inferior segments, though LV function was normal, which might predict that pericardial inflammation in the echo. This is not a specific marker or like that, but we can assume that. The first ECG which I shown, this was the first ECG on presentation. Basically, on this ECG, mostly we consider as an acute inferior olema, even though she is a female. There was no significant any pericarditis change like PR depression or like that. But definitely as the ECG evolved and we rule out any other causes like angiography, echo and other things, we then finally came to diagnosis as pericarditis. So basically this is a very atypical presentation of a pericarditis, and which we can easily confuse with an MI. Quantitative is not so much elevated, around 0.1 to 0.2, but definitely on the positive side. Okay. Even CT thorax was also done. I don't have the report, but it was reported to be normal. Okay, thank you.
Thank you. Now I request chairpersons to be seated, and Dr. Suvankar Ghosh will present his interesting case. Dr. Suvankar Ghosh is an interventional cardiologist and consultant at Bankers Group of Hospital.
Good evening, everybody. So today I'm going to speak about a case study that is a very unique one. Introductory details is a patient of 71-year-old male, non-hypertensive, non-diabetic, presented with a for us acute onset of chest pain, perspiration, dyspnea at rest, and giddiness. He had a history of ischemic CV stroke 5 years back, but with no residual deficit. On admission, pulse was 40, BP was 100/70, and bilateral Krebs. This was his ECG, as we can see. I would like to ask you as to what do you see, or rather, let me just show you the ECG properly and ask you, what do you see in the ECG? Is it a complete heart block, anterior wall myocardial infarction, sinus bradycardia, or sick sinus syndrome? Can we have the time, please? So we have a complete heart block. Well, as a matter of fact, it was just sinus bradycardia, and with 40 beats per minute, and there was an SC segment depression in V2 and V6 with T wave inversion, QT prolongation, left axis deviation, and mild ST elevation in AVR and V1. Blood investigation revealed just that the creatinine was a little elevated. Other than that, everything was pretty normal. And the 2D echo showed severe hypokinesia of LAD and LCX wall segments with EF of 30%, mild MR, moderate AR, mild TR, and mild PAH. So this was the angiogram that we can see. So here we can see that in the angiogram that the left system is totally shut down right from the proximal edge of the coronaries, and the right coronary has got mild disease in its mid segments. So what would be your optimal therapeutic measure for such kind of a patient who has a total occlusion of the LCA and just mild disease in the RCA? What would you like to go ahead with? Can we have time, please? So maximum people going for balloon angioplasty. Okay, so this was our course of therapeutic action. Well, the patient was given a loading dose of antiplatelets, like ticagrelor and aspirin, BiPAP support, inotropic support, and transfer to the cath lab. CAG was performed by right femoral root and supported with temporary pacemaker, which revealed total occlusion, like I just showed you. And thus, considering that the patient was in cardiogenic shock with acute LMCA occlusion and immediate primary PTCA to LMCA, bifurcating into LAD and LCX with an IBP support was planned. So after the IBP insertion with the help of a 7 French 3.0 XB guiding catheter, the LMCA was cannulated, but as soon as the guide wire was passed through the LMCA and into the distal segments of the LADA, our scout angio surprisingly revealed a spontaneous recanalization of the LMCA with TV3 flow in both LAD and LCX. There was, however, a mid-moderate osteoproximal lesion and LMCA followed by another mild lesion in the mid-LAD involving the osteal diagonal 2 with practically normal codominant LCX. So this was how it looked after we crossed the... So a completely occluded LMCA all of a sudden just opened up right after just passing the wire. In other views also we can see very clearly that there is complete recanalization of the entire left system. Hardly you can see there is some amount of lesion in the mid-LAD and the LMCA. So the possibilities, I mean the possible reason for such a spontaneous recanalization can be due to resolution of the thrombus of the unstable plaque in LMCA after IV heparin and antiplatelets introduction, or embolism of LMCA, that is due to air embolism through the catheter or LV clot embolization into the LMCA. So what would be your further line of action? Go ahead with PTCA and stent the place, further investigate and imaging medical management in the ICU, or just send the patient for a CABG surgery. Can we have the time, please? So most people would like to go ahead with the PTCA, but since the entire situation was not very clear, so we decided to go further with some more investigation and imaging, because we do have an IVIS. So considering that the possibility of an unstable plug in the LMCA with non-obstructive moderate lesion in the LMCA and LAD, IVIS of the LMCA and LAD was performed. However, the IVIS imaging revealed insignificant plug burden in the LMCA and LAD with minimal Newman areas. So this was the IVIS that was pulled right from the distal LAD, and as we come up from the distal LAD into the mid LAD, we can start noticing some plaque burden in the mid LAD and drawing up into the LMCA. So just subsiding this, we can see that there is the first slide, the first picture is of the distal LAD, where we can hardly see any plaque. The second picture is of the mid LAD, where we can begin to see some plaque in the distal segments here. And as we go further up, the plaque pretty much clears up into the proximal LAD, but in the distal LAD again we can see some plaque in there. And lastly, we can see by measurement also, we can see that the plaque burdens in the mid LAD as well as in the LMCA is quite insignificant. So eventually, post spontaneous recanalization of the LCA, the patient became hemodynamically stable, the heart rate normalized, the blood pressure rose up to 120 by 70, and considering that there was spontaneous recanalization of the LMCA and mild non-obstructive lesions in LMCA as well as in the LAD and LCX, patient was shifted to the ICU without further intervention with IABP support and TPM. But as fate would have it, merely 30 minutes after the patient was shifted into the ICU, in a fairly stable condition, he suddenly dived into severe hypotension and his intrinsic heart rate grew below 40 and was completely dependent on the TPM. The patient grew drowsy and his saturation rapidly began to fall. He was immediately intubated and with ventilatory support was transferred back into the cath lab. Check angio. Sadly, the check angio revealed a reocclusion of the LMCA soon after the patient went into cardiac arrest and CPR was initiated. As you can see, just 30 minutes before in the cath lab, the entire left system had totally recanalized and there was no sign of any thrombus whatsoever. But soon after, the next time we took him into the cath lab, the entire LMCA shut down as it was before. So, as soon as the patient developed cardiac arrest on the cath lab table itself, after the check angio, the CPR was initiated and 2 wires were consecutively passed through the LMC and into the distal segments of the LAD and LCX, thus partially revascularizing the left system. And then thereby, after wearing the LAD and the LCX, a bailout stenting of LMCA into the LAD was carried out with 3.5 by 38 millimeters DES, as we can see in these 2 slides, right from the austere LMCA and into the almost the mid LAD segment. Yeah? And this was the final result that we achieved after stenting. We can see that the entire left system is again totally revascularized, but even post-stenting and achieving adequate flow into the LAD and the LCX, however, the patient remained in cardiac asystole, and in spite of continuous CPR and all possible rigorous resuscitation measures, the patient unfortunately could not be revived. So, lastly, the question that's been lingering, I guess, in everyone's mind is that were our line of therapeutic actions justified? Right? Yes? Partially? No? Or no comments? Partially. Okay. Those of you who answered partially, could you just be a little elaborate and say how would have done things differently? Anyone who said partially? No? Okay, who said no, for example? Okay. How would you want to go about it then, sir? Right. No, no. I guess I was just showed that there was some mild plaque, sir. That's it. Unstable plaque.
What you say is absolutely right, that for unstable plaque, put a stand, okay? But sand does not allow us in a way, because in that scenario, to diagnose unstable plaque with IVOS would be extremely high. And in a normally looking vessels, you will start putting stands. Okay, so that's the dilemma. If I were given a choice again, I would put a stand. But in that scenario, anybody coming with an unstable angina, with an unstable plaque, and normally filling LAD, I would not put a stand. I mean, that's the message.
Okay. So, concluding, we would like to say that acute LMC occlusions usually present with cardiogenic shock, has very high mortality rate and prolonged hospitalization with very poor prognosis. Mechanical support in the form of IBP, temporary pacemakers are essential in addition to immediate revascularization. Unstable plaque in LMCA is with superimposed thrombus formation can sometimes resolve spontaneously. However, in most cases, it should be stabilized by stenting to prevent possible reocclusion as it occurred in this particular case. IVS imaging may be helpful in providing further information in the form of plaque morphology, plaque burden, internal lumen, thrombus, true vessel size, lesion length, thus assisting in the plan of therapy. Thank you.
Thank you, Dr. Ghosh. And we here come to the end of academic program for Cardcon 2019.
Sorry, sir?
Have you discussed this case in an interventional cardiologist forum?
This is the first time we have presented this case, sir.
Okay. I'd like to see other opinions from cardiologists.
Sure, we will.
Thank you, chairpersons. Thanks a lot. Thank you to our esteemed audience for coming to Cardcon time and again. And we'll promise you equally entertaining and academically oriented Cardcon again in 2020. And thank you all for being with us time and again. Thank you. The doctors and staff from Bankers team, please remain seated in the auditorium, please.
Hi, and